were on long-term complications after extrahepatic cyst, excising for type 4A choledochal cyst. The topic for today's discussion is natural course and disease-modifying strategies in compensated liver cirrhosis. May I request him to please begin with this topic?
Which is very prevalent. I think most of our chronic patients, 50% of patients are related to liver disease, cirrhosis of the population. And I think for that, we don't have better person than Dr. Ramesh Kumar, who is an earlier in
Very good morning and thank you sir for kind introduction and just coming to topic. This is what happened when another asymptomatic patient is being told that there is cirrhosis. There is situation like panic and a lot of questions started coming up. And this scenario is quite common nowadays because of advent of non-invasive marker of liver fibrosis, especially fibroscan. So much so that even Bavino has come up with a new terminology, compensated advanced chronic liver disease, which includes not only compensated cirrhosis but also CLD with advanced fibrosis. And they have also suggested two cutoffs, to rule in and rule out the compensated advanced chronic liver disease in any patient with chronic liver disease. So this leads to early detection of cirrhosis, and this is good in a way not only to the patient but also for the clinician, so that a timely intervention can be done and to change the trajectory of natural evolution of cirrhosis. So let us try to understand what is compensated cirrhosis. Any cirrhosis without a history of one or more decompensating event is called compensated cirrhosis. And the first decompensating events are ascites, peripheral hemorrhage, and hepatic encephalopathy. It is noteworthy that presence of subclinical ascites, non-variceal bleeding, or portosystemic encephalopathy are not considered to be decompensating events. Therefore, history of any such event should not lead to misclassification of compensated cirrhosis as a decompensated cirrhosis. Coming to natural history, we can see that most of time of cirrhosis is being spent on the compensated stage. As we can see here, the median survival of compensated cirrhosis is around 12 years, and in decompensated cirrhosis, it is only about 1.8 years. Therefore, the first decompensation is considered a prognostic watershed in the natural history of cirrhosis, because it indicates not only a drastic decline in survival rate, but also a definite sign of no return from here onward. Because decompensation is the most important event in the natural history of cirrhosis, so it is important to know how decompensation happens. So there are actually two types of decompensation that can be seen in patients with cirrhosis. One is acute decompensation, which usually happens in a day and associated with some precipitating event. And second is non-acute decompensation, which is because of the gradual progression of disease process. And from here onward, most of the patients progress to death or liver transplantation. However, in minority of patients, recompensation is also a possibility. So coming to acute decompensation, which happens in about 50% of patients, these are the important precipitating factors like infection, alcohol, and viral hepatitis are the commonest one. And after an event of acute decompensations, studies have found three patterns emerging. About 20% of patients goes on to develop acute and chronic liver failure with a mortality rate of 67% in 1 year. 20% of patients develop unstable decompensation with mortality rate 35% in 1 year, and majority of patients have stable decompensation with mortality rate less than 10%. And this is how non-acute decompensation progresses. The rate of transition from compensated to decompensated cirrhosis is around 5 to 12% per year. And majority of decompensation, the maximum risk is within the 1 year of diagnosis. And there are certain risk factors which predisposes patient to have increased chance of decompensation, like persistent etiology, portal hypertension, inflammation, diabetes and hypertension, obesity. I've already enumerated these are the risk factors for decompensation. Although we know the median survival of compensated cirrhosis is very large, around 8 to 12 years, but predicting survival in individual patient is very difficult because the conventional method like CTP and MED score doesn't help in patient with compensated cirrhosis. What can help here is the presence of clinically significant portal hypertension. So we can see here, if patient doesn't have evidence of clinically significant portal hypertension, the 5-year mortality rate is only 1.5%. But when there is a clinically significant portal hypertension, the mortality rate varies from 5 to 10%, depending upon absence and presence of varices. So clinically significant portal hypertension that signifies hepatic venous portal gradient more than 10 is an invasive test which is not normally available in majority of centers. So what we can use is some of the non-invasive indicators like fibrous scan. A liver stiffness more than 25 is sufficient to rule in clinically significant portal hypertension, and when liver stiffness is less than 15, we can rule out clinically significant portal hypertension, particularly when platelet count is more than 1.5 lakhs. Now coming to goal of therapy. So goal of therapy in patient with compensated cirrhosis is, of course, to achieve reversal or regression of cirrhosis. But if it is not possible, the next goal should be to prevent and delay the first decompensation. So is reversal of cirrhosis possible? Yes, because liver fibrosis is considered a dynamic process where the fibrosis can remodel, and hence the cirrhosis can also be considered a dynamic disease with potential to regress. In fact, Wanless et al. First described reversal of cirrhosis in year 2000, and thereafter there has been a series of publications showing reversal of cirrhosis with cirrhosis of various etiologies. We can see here the reversal of cirrhosis. The magnitude of reversal that has been documented is much higher in viral etiology of cirrhosis than non-viral causes. In hepatitis B, the reversal to the tune of 74% has been described. So is all cirrhosis is reversible? Answer is no. Only early cirrhosis that lacks significant cross-linking of extracellular matrix and marked angiogenesis are reversible. There are certain histological predictors of reversibility, like the most important being the thin fibrous septa. But for that we need to have liver biopsy. The most important factors which leads to reversal of cirrhosis is the elimination of underlying cause. There is no currently any approved antifibrotic drugs, growth factors or stem cell which can lead to reversal of cirrhosis. So if the achieving first goal is not possible, the next goal has to be prevention, or at least delaying the first decompensation, because decompensation is the most sinister event in the natural history of cirrhosis. So we all know that the most important driver of progression from compensated to decompensated cirrhosis is clinically significant portal hypertension. As we can see here, when portal gradient is less than 10, the risk of decompensation is very low, less than 10% in 4 years. And when it is more than 20, the risk of decompensation is about half percent within 2 years. And this is the first proof of concept of controlling the portal pressure and leading to reduced risk of decompensation. Pritisky trial, which was published in Lancet 2019, and this was the multicentric trial from the Spain, and this was a very elegant trial which clearly showed that giving beta blocker, either propranolol or carvedilol, leads to reduction in decompensation, 16% in treatment group versus 27% in placebo. And the most important difference was because of reduced incidence of ascites, which is the commonest form of decompensation. And the same results was later documented on a meta-analysis of 4 RCTs, which found that giving carvedilol reduces the risk of decompensation by about 40%. So, although not in the guidelines, beta blocker can be recommended in any patient with compensated cirrhosis who have clinically significant portal hypertension. And for early cirrhosis, carvedilol is better than other beta blocker. There are various strategies for delaying the decompensation in such patients, like removal of cofactors. Studies have found that obesity, diabetes, and continued alcohol intake increase the risk of decompensation. Therefore, this has to be controlled. There are certain drugs which has favorable impact on the natural history of cirrhosis, like statin, anticoagulation, vitamin D, and coffee also. I don't have time to discuss everything in detail, but just going through the slide briefly. Obesity increase the risk of decompensation by 3-fold. So every compensated cirrhosis patient, but particularly those who are obese, should be advised to have loss of weight by lifestyle changes. Coming to role of statin. Statin has multiple pleiotropic effects and which may be beneficial in patients with cirrhosis, and various community-based studies have found that statin reduces the risk of decompensation by about 40 to 60%. However, we need robust data for as of now, we can say that we should not avoid statin in presence of dyslipidemia. Endothelial damage and occlusion of small hepatic vein can cause parenchymal extension, and which has major role in progression of cirrhosis. Therefore, anticoagulations can be tried in such patients. Even small RCTs have found that enoxaparin can decrease the risk of decompensation. However, further studies are required before it can be recommended in the day-to-day clinical practice. Vitamin D deficiency is very common in cirrhotic patients, and we know that vitamin D deficiency has correlation with severity of various etiology like NAFLD and SCV infection. Therefore, if vitamin D deficiency is there, it must be corrected. Regarding salt restriction, there is no guideline as of today, although we know that even in compensated cirrhosis, the renal sodium retention happened. Consumption of salt by normal population in India particularly is very high, around 10 to 12 grams per day, which is much higher than the normal recommended salt consumption by WHO. Hence, it is always prudent to recommend salt restriction even in patients with compensated cirrhosis. So, this is my take-home message. Survival of patients with compensated cirrhosis can be enhanced by doing early diagnosis, elimination of underlying cause, control of portal hypertension, managing the modifiable risk factor like obesity and hypertension, diabetes, and prevention of precipitating factors like viral hepatitis infections and drugs, especially nowadays there's increased use of CAM and all. Thank you.
Thank you, sir, for your insights on the topic. I would request you to please kindly be seated on the dais itself. Now I would like to invite our next speaker of the session, Dr. Virendra Singh, to kindly come up on the dais. Dr. Virendra Singh is a member of several societies at national and international forums. His expertise lies in ascites, AKI, vasopressors, hepatic regeneration, alcoholic hepatitis. With over 275 publications and 3,500 citations, he has been vigorously involved in research purposes. His topic for today's discussion is management of refractive ascites in the year 2023. I would like to request him to kindly begin with this topic.
Thank you. I'm thankful to the organizers of this conference, Dr. Vijay and Dr. Dayal. This is actually looks like my alma mater. I worked here for 2.5 years, so I'm familiar with all the doctors here. In the next 15 minutes, I'll be discussing the refractory ascites, its management in 2023. Let us come to the pathogenesis. In cirrhosis, there is a portal or the sinusoidal hypertension, which causes the splanchnic or the systemic vasodilatation, which causes the decrease in the effective arterial blood volume and activates the vasoconstrictor and the anti-natriuretic factors, which leads to the sodium and water retention, causing ascites and hyponatremia. And on the other hand, there is an increased cardiac output, high output heart failure that causes the decreased renal blood flow and then leading to hepatorenal syndrome. So the various steps where the ascites can be controlled is the one is the sodium restriction, another is the use of diuretics, then another is the large volume paracentesis, or we can take help of tapes, or if nothing works, then the patient goes for the transplant. We can also use the various vasopressors. Now coming to the definition of refractory ascites. The refractory ascites, the criteria, the diuretic resistant ascites or the diuretic intractable ascites. The diuretic resistant ascites, if the ascites is uncontrolled with salt restricted diet of less than 90 millimoles per day, or with the 400 mg of aldactone plus 160 mg of furosemide, then it is called the diuretic resistant ascites. The diuretic intractable ascites, when the complications prevent use of adequate doses of diuretics. This is the definition, the criteria for the refractory ascites. The treatment duration should be the patient must be on intensive diuretic therapy. That is the maximum dose, that is spironolactone 400 mg and furosemide 160 mg for at least 1 week and on a salt restricted diet for less than 90 millimoles per day. The lack of response when the mean weight loss of less than 0.8 kg over 4 days and urinary sodium output less than the sodium intake. If there is a reappearance of the grade 2 or 3 ascites within 4 weeks of initial mobilization, then we call it a recurrence. Then the diuretic induced complications can occur. The diuretic induced hepatic encephalopathy is the development of encephalopathy in the absence of any other precipitating factor. The diuretic induced renal impairment is an increase of the serum creatinine by more than 100% to a value of 2 mg per dl in patients with the ascites responding to treatment. We have recently updated the APASL guidelines on the management of the ascites, and in that we have suggested that the definition, the old definition of the AKI which is taken here in the refractory ascites should be changed to the newer definition, that is the rise in serum creatinine of more than 0.3 mg per dl within 48 hours or more than 50% from the baseline value, that is last available output serum creatinine within 3 months and a urine output of less than 0.5 ml per kg body weight for more than 6 hours. The diuretic-induced hyponatremia is defined as a decrease of serum sodium by more than 10 millimoles per liter to a serum sodium of less than 125. The diuretic-induced hypo or hyperkalemia is defined as a change in serum potassium to less than 3 millimole per liter or more than 6 millimole per liter despite appropriate measures. When the refractory ascites develops, the survival goes down. The various options for managing the refractory ascites are, if these patients are receiving the beta blocker, you have to stop it. If there is a hypotension, then you have to add metodrin. You can take help of the serial therapeutic paracentesis. You can do tips in these patients, or if nothing works, then the liver transplantation. The large volume paracentesis is very useful in these patients, and they compared the LVP versus the diuretics, and it was better than the diuretics used. If there is no urinary sodium excretion, the paracentesis usually will be required in every 2 weeks. How to check this, how this value of 2 weeks comes, in the dietary compliance can be checked. If you are taking out a 10 liter of the paracentesis, that will remove 130 into 10 is equal to 1300 millimole sodium. So patients consuming 88 millimole sodium per day, that is 2 grams of salt, excrete 10 millimoles per day non-urinary sodium, and they retain 78 millimoles per day. Therefore, 10 liter paracentesis removes 17 days of retained sodium, that is 1300 divided by 78, that is 16.7 in patients with no urinary sodium excretion. The patients with some urinary sodium excretion should require paracentesis even less frequently. If not, probably they are not complying with the salt restricted diet. The other way, you can take help of the spot urinary sodium and potassium ratio. If it is more than 1, that indicates a 24-hour sodium excretion of more than 78 millimoles. The major problem in these patients after the large volume paracentesis is the PICD. And in PICD, in patients with the cirrhosis, there is a arteriolar vasodilatation which causes the decreased effective arterial blood volume, and then this can be prevented by giving 6 to 8 grams of the albumin of the per liter of the fluid removed. This is what happens after the LVP. Even after the albumin infusion, the LVP, this PICD is seen in these patients. If you don't use albumin, then the prevalence is quite high. This is a landmark study done by Maru et al. And published in Gut in 2002, and he compared the prevention of PICD with the help of terlipressin and compared it with the albumin, and this was useful. This is our study. The guide, I was guide, and the main candidate was Ramesh, the previous speaker. He was my first MD candidate, and this work was done, and this was published, and this was the 40 patients in which we compared the PICD in patients receiving the albumin and the terlipressin, and we could prevent the development of PICD. Then, because the terlipressin was costly and it was very difficult to get it that time, so I switched over to NORAD, and then the prevention of PICD could be done with the use of NORAD. Then we changed it to the metodrin because both were injectable. Then this is an old drug, and this causes the vasopressor. This is another vasopressor, and in this we compared the albumin and the metodrin in the 2 arms in 40 patients, and we were able to prevent the PICD with the metodrin also. But this is another study in which the prevention of paracentesis induced circulatory dysfunction with the metodrin versus the albumin. This was in 24 patients randomized to receive either metodrin and the albumin. PICD developed in 60% of patients in metodrin group and 31% in patients in the albumin, so it was not helpful. This is a meta-analysis in which Bernardi compared the 2 groups, that is those receiving the albumin, those receiving the vasopressor, and he proved that the albumin was superior to the various vasopressors. And probably this was because the vasopressor arm contained very few patients. And the newer therapies, we also use the midodin for the control of refractory or the recurrent ascites. In this, we involved 40 patients. The midodin was used in 7.5 mg 8 hourly, and the primary endpoint was the control of ascites. Secondary endpoints were the survival and all. And here you can see the MAP increased, the cardiac output decreased, the SVR increased, urine output and the urinary sodium increased, PRA decreased, and the survival also was better in the midodin group. In this study, they also used the midodin, and this was again useful in controlling the recurrent ascites. On the other hand, this is a US study in which they used the midodin and they could not prove the usefulness of the midodin in patients with the LVP and those undergoing LVP. We also used the clonidine along with the midodin, and then the combination group did not show any superiority. The midodin and the combination of the midodin and the clonidine did not show superiority, and the midodin was useful in controlling the refractory or recurrent ascites. We also used the midodin along with the tolvaptan in these patients. There were total of 50 patients in 4 groups, and the midodin was given in the doses of 7.5 mg 3 times a day, and tolvaptan in the doses of 15 mg 12 hourly. Midodin as well as the combination of midodin and tolvaptan plus the SMT was superior to SMT alone, as well as tolvaptan in the control of ascites. The combination therapy was superior to midodin in the control of ascites at 1 month. The mortality and the frequency of complications was similar in all the groups except the SMT, and with the renal failure was observed in significantly higher number of patients. The long-term administration of the albumin also improved the survival in patients with the cirrhosis and refractory ascites. This was done by Pascoli and published in 2019, and this would have better the survival in those patients who were receiving the long-term albumin. This is the landmark study, the ANSWER trial, in which they looked at the efficacy of the long-term human albumin administration in patients with the decompensated cirrhosis. It was a multicentric randomized parallel open label trial in 33 Italian hospitals, and then in that they gave the human albumin 40 grams twice weekly for 2 weeks, and then 40 grams weekly for up to 18 months. And the overall 18-month survival was better in the albumin group. The hyponatremia episodes were lesser. The ascites cumulative incidence of the first paracentesis and refractory ascites also decreased in patients, those who were receiving albumin. This is another study, although it was a negative study, the combination of the midodin and the albumin in these patients, but there were various problems in this study. The dose of albumin which was given was a lower dose, and then initially they enrolled 196 patients, but the therapy could be completed only in a very few, that is the 9 patients only. So there are inherent flaws in this study. The tips can be taken help in the control of ascites. These are the various studies in which the tips was compared with the large volume paracentesis. The tips is useful, but there is slightly higher chance of the encephalopathy. However, in this study in which they used the 62 patients with the recurrent ascites, the encephalopathy was equal in the 2 groups. The alpha pump, the automated low flow ascites pump, can be used, and in this what happens, they will put a catheter from the ascitic fluid into the bladder, so the whole ascites is drained through the urine, and this is an automatic pump is there. This is an initial study in which they compared it, and it was a multicentric non-randomized trial. However, the pump system removed 90% of the ascites and significantly reduced the median number of LVP, but the complications were quite high. This is another study. Again, There were, again, the serious complications were quite high. So to conclude, this is the approach to the management of refractory ascites. If there is cirrhosis with ascites not responding to usual measures, you look at the diagnostic tab and the SBP should be ruled out in these patients. Look at the ADA also, many of these patients may have tuberculosis. The restrict dietary sodium, stop alcohol, don't use NSAIDs, treat etiology, look at the HCC, stop beta blockers, and you can take help of the LVP with the midodrine. With the albumin, if there is a low MAC, you can use midodrine or send this patient for TRACE, and if nothing works, do the liver transplantation. Thank you.
Thank you, sir, for your insights on the topic. We now hereby are open for discussions on the topic, and we also invite queries from our listeners. We request our chairpersons on the dais to set about the discussion.
For Dr. Ramesh, we have many patients in our clinical practice who are in compensated CLD phase, who have persistent elevated bilirubin levels, and none of the guidelines or the literature tells us specifically how to manage that, or what does it signify. Does it signify more worse prognosis, or what to do about that? Persistent low elevated bilirubin level over years.
It depends upon what kind of bilirubin rise is there. Is it unconjugated or conjugated one? If unconjugated is there, he might be having something like Gilbert syndrome, where the mild hyperbilirubinemia is common. But if bilirubin is more than 3 and mainly dilate, the patient is going to be in child-based cirrhosis. So he is in fact decompensated.
A patient with the ACLF-like picture. So you will have to dig into the problem here. Many of these patients, if you look at the infection, do the ascitic tab and you will find SBP. So, and get an X-ray chest, look for the urine examination. These are patients harboring infection somewhere. The infection is the commonest problem in these patients with the decompensated cirrhosis. If the bilirubin is high, you have to look for the infection.
No one touched it. Thank you, sir, for nice presentation. The question is for detection of infection in patient of cirrhotic ascites is very difficult. We have done many of the ascitic fluid paracentesis, sent ascitic fluid in blood culture water, but nothing comes out. In majority of more than 90% of it comes negative. Second, even we suspect patient has developed recent AKI and suspect infection, but even in those cases ELC and neutrophil counts are low. In those two situations, what are you doing to improve, to detect the detection, or we are missing something in treating this patient?
See, this is the impression which I also carried when I was working here. And once I joined PGI, there's probably problem at the microbiology department. You look at that. See, the positivity rate is not that 90% negative. No. See, roughly 50% patients will have 50 or 60% will have the culture positive bacteria. And most common is the E. coli. So you will have to look at your lab. That is one thing. Then the second question is regarding the leukocytosis is not there, but the AKI is there. It is not necessary leukocytosis. See, if you are doing an ascitic tab, the cells are not raised, then it means, and the condition is not improving, the AKI is not improving. You look at the other factors, and if nothing is found, you do a repeat tab, a diagnostic tab maybe after a week. You will find that in the previous diagnostic tab, there was nothing. But in the second, there is a SBP. So probably this was early stage where you are not able to pick up the cells in the ascitic fluid. but when you repeat it, then you will get it.
What instructions to be forwarded to our microbiologist to improve the sensitivity of ascites to culture?
I am not a microbiologist, but the best is the send at least in the blood culture bottle, and you can send the repeated cultures. If you are suspecting SBP and you are not getting it, it means there is something wrong somewhere. See, it is not so difficult to make diagnosis of SBP even clinically. See, these patients come to you in OPD and you find no symptom, you will say this is okay, I will not do a diagnostic test. Never, never. Do a diagnostic test. And when you look at the map is low in these patients. When you do a renal function test, creatinine is very minimally raised. So all these features suggest that there is a SBP. In such a situation, if the count is not raised, it means there is some problem. So if you are clinically you are fitting and then the renal dysfunction is there, the map is low, in that case we can repeat it after about a week.
So choose what you want to share. Entire speech.
Regarding hyperbilirubinemia, I would like to say that if the indirect hyperbilirubin is raised, then you should also look for the presence of hemolytic anemia in that case, especially if the hemoglobin is on lower side. And as Sir has correctly said, the sepsis is one of the important factors if the persistent hyperbilirubinemia is there in presence of. And regarding the use of statin in compensated cirrhosis, there is a landmark study published in, I think, 2016 by Abrale et al., if I spell the name correctly, and that showed the use of statin decreases the mortality rate as in the patient of early cirrhosis. A study also published from this center also showed that simvastatin is effective, especially in the patient with compensated and the early decompensated cirrhosis to improve survival as well as the.
There is a randomized controlled trial of simvastatin after acute varicose bleeding. But for compensated cirrhosis per se only, there is only community-based studies and retrospective. So we need to have high quality of data before simvastatin, and because it has also got some hepatotoxic potential. So though it is very negligible. So.
Yeah, in that study, only the 2 cases of rhabdomyolysis was, they showed the 2 cases of rhabdomyolysis, but in that cases they used the simvastatin at the dose of 40 milligrams. I think simvastatin 20 milligram per day is a bit safer dose.
May I dare to interrupt, sir? We are running a bit late of time. We kindly request the chairpersons to please bind it.
Just for information, the management of the ascites, the APASL guidelines is published in Hepatology International. It is open access and anybody can download it. It is online.
Sir, in such type of patients, many patients have gynecomastia, in some patients. How can we manage? Dr. Jha is saying hemolytic anemia is very, very rare. It is not common. It is very uncommon in patients having decompensated cirrhosis having hemolytic anemia. It is very rare. You can get in some patients. Many patients have high bilirubin and have HRS.
These patients with the gynecomastia, it is a very frequent problem. And when you ask them, then they will tell you, otherwise they will not come out. And in that case, this is mainly because the spironolactone, we stop that, start with the amyloid.
Thank you.
We have had a very lively session, and I would like to thank both the speakers for the wonderful talks and also the audience. If there are any more questions, you can also.
We would request our chairperson sitting on the dais to please come forward to present a moment of appreciation to our speakers. our chairpersons for the next session of the day to come up on the dais. Dr. Hemant Kumar, Senior Consultant Nephrologist in Patna. Dr. B.K. Dubey, Professor, Head of Department of Anesthesia, IJMS Patna. Dr. Sanjeev Kumar Jha, Additional Professor, Department of Gastroenterology at IJMS Patna. Dr. Vijay Shankar, Consultant Gastroenterologist at IJMS Patna. And Dr. Amit Kumar Banga, Consultant Gastroenterologist at Big Apollo Hospital, Patna. Our first speaker of the session is Dr. Gaurav Pandey. He is joining us through a live stream. Good morning, sir. Can you hear us?
Hi, morning. Am I audible?
Yes, sir. May I have the honor to continue with your introduction? Dr. Gaurav Pandey, Additional Professor in Department of Gastroenterology at ISGCON Lucknow. He has established a new combination therapy to provide relief at the same time prolong the life of patients of liver cirrhosis, acute liver failure, and chronic liver diseases. His topic for discussion is current understanding of hemodynamic modulation in patients with ACLF and ascites. Thank you, sir. Please kindly continue with your topic.
Thank you so much for the kind invite. Thank you, Dr. Vijay. Thank you, the whole organizing team. I'm really sorry I'm not there. My daughter was sick and admitted, so I couldn't make it. I'm extremely sorry for that. I'll just start with the given topic, ACLF and altered hemodynamics and how to modulate. So these are the basic few thoughts that came to the mind when this topic was given to me. What is ACLF? And how does the liver failure cause other organ failure? Liver obviously does not go all around strangulating kidney, strangulating heart. So how does the liver cause so many organ failures? Is the weight of inflammation and altered gut permeability so much that the other organs are damaged? And if this is true, how to modulate this and prevent other organ damage? So as we all know, the definition of ACLF is slightly different as per EASL and APASL. APASL liver failure has to be there. EASL extrahepatic organ failure has been given more importance. But anyway, what happens is that when there is an acute insult, there is sudden increase in portal pressure. This will lead to backward flow of blood, gut congestion. Now, gut congestion will lead to gut dysbiosis, increased intestinal permeability, pathological bacterial translocation and endotoxemia. Obviously, this will lead to SIRS, and SIRS will, at a certain stage, does lead to immune paralysis, sepsis, and shock, and obviously multiplies into multi-organ failure. Now, though the name is ACLF, but look at the mortality. Only liver involvement mortality is not that high. Mortality jumps multiple times, especially when extrahepatic organ failures are involved, especially kidneys. So that is the crux. Though the name is only liver failure, but the mortality is determined by extrahepatic organ failure. So this is a cartoon that happens in decompensated cirrhosis, but almost similar pathophysiology happens in ACLF. Once you have a normal or slightly altered liver volume, hemodynamic volume, with the acute insult, progressively there is increased portal pressure, gut congestion. Gut congestion will lead to increased splanchnic vasodilatation. Splanchnic vasodilatation and gut congestion would lead to increase in PAMPs and DAMPs, altered permeability. This would reduce the amount of flow going to the heart. So that causes effective arterial hypovolemia. Now this PAMPs and DAMPs in the circulation would also increase the nitric oxide level in systemic circulation and would also lead to systemic vasodilatation. So we have a state because of inflammation and altered permeability where we have splanchnic and systemic vasodilatation both. Now this would in effect reduce the arterial volume available to the body. This happens in spite of maximum degree of activation of renin-angiotensin, aldosterone system, SNS, ADH. Body tries to compensate, but the insult is way beyond compensation. So there is the cartoon this given published in Nature by Professor Reen's group that shows that increased portal hypertension, gut congestion would lead to bacterial translocation, PAMPs and DAMPs, multiple cytokines and endotoxin into the circulation, leading to splanchnic and systemic vasodilatation and inflammation, which obviously with translocation leads to SIRS, sepsis and multi-organ failure. So important issues are increased portal pressure, bacterial translocation, release of pro-inflammatory cytokines, hemodynamic alteration, that is splanchnic and systemic vasodilatation. Then multi-organ cascade follows. So this was the importance of how inflammation, alteration modulates or exacerbates organ failure. We come to what is the evidence to this particular hypothesis. So what is the impact of high HVPG? Now high HVPG reduces the total blood flow. As you can see in the cartoon on the left side, as the HVPG increases, blood flow to the liver decreases. So this was a study published from ISGCON group that showed that the baseline HVPG is an independent marker of survival in patients with ACLF. So it's very apt that as soon as the portal pressures increase, the survival comes down. Now leaky gut. Leaky gut, is it a conjecture or can we measure? Most of the articles do mention this term leaky gut. Is it objective or subjective? Now we did this simple lactulose mannitol test to assess how much is the gut leaky. It's a very simple test. You have to give oral lactulose and mannitol to the patient. Mannitol basically has a transcellular absorption, but lactulose does not have a transcellular absorption. Lactulose is absorbed paracellularly. So only its concentration will go up only when the gut is leaky. So if the lactulose concentration is high, lactulose mannitol ratio is altered, and this alteration keeps on increasing as the severity of liver dysfunction, decompensation and ACLF increases. So this in fact has a linear gradient. This we have published recently. So linear increase in altered gut permeability happens with the progression of ACLF and liver disease, and then the whole cascade of PAMS, DAMS, leakage, SIRS and organ failure happens. Now we have established that the gut is leaky. Now does endotoxemia from the leaky gut impact the circulation? There was a very old animal study done in 2006 in which they looked at the impact of endotoxemia. So this was a rat model in which when they injected endotoxins, lipopolysaccharides into rat, the GFR from 150 became 50. It decreased by more than 2/3 of the baseline GFR. So such is an impact of endotoxins, that only endotoxins alter the circulation and reduce the GFR by 2/3. Once pentoxifylline was added to counter that, GFR increased. So such is the impact of endotoxins. Endotoxins obviously, if countered by pentoxifylline in human data, reduces the probability of renal failure and hepatic encephalopathy. So endotoxin again is a very powerful tool hampering the prognosis in patients with ACLF. This is again the whole cartoon leading the impact of what altered permeability does. So once you have this condition where the gut is leaky, there is endotoxemia, there is splanchnic vasodilatation, worsening systemic vasodilatation, you will have increased heart rate, decreased MAP and increased stroke volume as the severity of cirrhosis, decompensation and ACLF happens. This was one of the recent studies published from our center in which we looked at the compensated cirrhotics, refractory ascites and ACLF patients and looked at their hemodynamics. As you see, this is the ACLF group. They had the highest heart rate, stroke volume, cardiac output, lowest systemic vascular resistance, that was only 598 times compared to 115 normal people. The MAP was much lower compared to refractory ascites or compensated cirrhosis. So it is a progressive deterioration that happens as the severity increases. Now, once you have altered permeability and you have bacterial DNA positive endotoxemia, you look at patients who had bacterial DNA positive, had much higher TNF alpha, nitric oxide, much lower MAP and HDR. So this all suggests the impact, the clinical impact of these particular pro-inflammatory cytokines endotoxemia that they have on the body. Now what happens to the cardiac reserve? in patients with hepatorenal syndrome or AKI, that is by ESL criteria, would be taken as ACLF, irrespective of bilirubin level. The cardiac output, stroke volume, and changes in heartbeat, heart rate is much lower in patients with AKI ACLF. Again, looking at the cardiac reserves are much lower when creatinine is more than. In fact, the survival is based on the circulatory dysfunction. This cartoon shows that the survival is not based on bilirubin levels or INR levels. It is based on circulatory dysfunction. Has such an impact on ECLF that until monitored and corrected, the survival is not going to improve. That is why people are struggling with improvement in survival in ECLF. Again, looking at the inflammatory markers, CRP if high suggests a bad prognosis. Higher the CRP, worse the prognosis. Again, that's the impact of inflammation. One of the elegant studies showed that the levels of IL-8 and PRC was much higher in patients with ACLF, and the strength of association of ACLF with systemic inflammation was higher than with systemic circulatory dysfunction. So again, a very powerful tool to assess mortality. The problem again is about albumin. I put this slide because in the therapy that we discussed, I used albumin here at the SGPK study that we did. And this is because in ACLF, the albumin that is in the body is oxidized and not functional. So until you give fresh albumin, the non-osmotic effects of albumin will not be present in these patients. So in a nutshell, portal hypertension, bacterial translocation, inflammation, reduced effective circulatory volume leading to multi-organ failure. This is a progressive stage disorder. So in a nutshell, it is not only the liver, it is the heart, the gut and the kidney that is defining the overall survival of this patient. This clinical manifestations of the vicious cycle increases the mortality. This is again the cartoon that I had drawn to imply what therapy we are giving. Now we have a patient with ACLF, increased creatinine, who has splanchnic vasodilatation, systemic vasodilatation, hypoalbuminemia and dysfunctional albumin. So we have to consider vasoconstrictors and albumin and mobilize the fluid. So for this, we recently published a response-guided therapy of albumin with vasoconstrictors that has terlipressin and NORAD. This combination was taken to reduce the side effects of each drug. Plus, terlipressin would act more on splanchnic and NORAD more on systemic. You require both at a lower dose with lower side effects. And once you attain a reasonable MAP and GFR, add furosemide to mobilize the fluid, reduce the gut congestion. It is paramount. So people who were treated with this therapy obviously had a better survival. The survival was improved to the tune of 30% over 90-day follow-up. This was the 30%. At 30 days, again at 90 days, it was 28%. Difference between the two arms that was there. And patients who could achieve urinary sodium of more than 80 millimoles early had much better survival. Probably this was dependent on how bad the hemodynamics were. So you see the baseline hemodynamics and at discharge. So SVR had improved from 600 to 1300, almost doubled. SVRI had improved. Stroke volume had decreased significantly. Arterial compliance had decreased. The MAP had improved. RARI had decreased. So overall, significant improvement in peripheral and systemic hemodynamics happened with this gut mobilization, vasoconstriction, albumin, and addition of furosemide to improve the fluid levels of the body. This is just the cytokine levels that improved during this as soon as we mobilize the fluid, and this graph shows the improvement in permeability and endotoxins, interferon alpha, IL-4, IL-6, IL-10. With this improvement and endotoxins decrease, the netosis or the neutrophil dysfunction increased. Immune paresis that had happened improved, and these patients developed much less infection in the body. So with neutrophil dysfunction improvement, much less incidence of sepsis and improved survival. The permeability obviously came down to baseline with this therapy. The IP and the endotoxin decrease, and intestinal permeability and endotoxin showed a linear decrease. So as soon as IP decreased, endotoxemia started decreasing. The whole paradigm that had shifted towards the right was significantly shifted towards the left with improved hemodynamics and echo parameters as shown. So in a nutshell, ladies and gentlemen, this is my last slide. Improving the hemodynamics with a combination of albumin vasoconstrictors in ACLF is again an alternative therapy short of transplantation to improve the survival. The topic was basically on altered hemodynamics, so I have not touched into liver transplant and other modalities of ACLF. I have restricted myself to this topic. So correcting altered hemodynamics may help improve survival in these patients. I'll be happy to take any questions.
Thank you, Dr. Gaurav, for summarizing such a comprehensive topic. Now the session is open for the House.
Thank you, sir, for your insights on the topic. I would request you to please kindly be connected with us as we proceed with our session. Our next speaker of the session needs no introduction. Dr. S.K. Sarin, sir. He's a senior professor and head of Department of Hepatology, Director of Institute of Liver and Biliary Sciences. His research has helped describe two major liver diseases, portal biliopathic and acute on-chronic liver failure. He has developed or significantly contributed to the development of several treatment protocols for liver diseases, such as band ligation to prevent variceal hemorrhage. His topic for discussion is how to handle challenges in managing ACLF. Unfortunately, due to some unexpected circumstances, Sir couldn't join us at the moment. We have this recorded presentation that would be running on us.
Greetings from the Institute of Liver and Biliary Sciences. I am grateful to Professor Dayal and Professor Vijay Shankar for inviting me. I would share some of the new thoughts on managing ACLF and the challenges. I have nothing to disclose. ACLF, I will divide this section into what we have learned in the last decade and what are the challenges. There are two definitions and the debate goes on. The easy definition is extrahepatic organ failure centric, and sepsis drives the organ failure. In the APSL definition, liver failure is the core and that drives organ failure. Let's look at some data of last 1 decade. So the canonic study, which included 1300 odd patients, if you will see, liver failure was present only in 14% of the patients, while kidney failure was in 18%, lung failure, coagulation, they were all separate. 2 organ failures and 3 organ failures were already present in about a third or 3/4 of the patients. Now, with this definition, without a liver failure, without jaundice, a decompensated cirrhosis may have kidney involvement. Will that call as a ACLF? For example, there is a patient who has got infection and has liver disease. Will that be called as acute on chronic? Let us take the example of chronic pancreatitis. You have a patient with chronic pancreatitis who gets pneumonia. He gets sepsis or he gets AKI. Will you call such a patient of chronic pancreatitis as acute on chronic pancreatitis? Probably no. So this whole concept of having a cirrhosis who gets AKI alone or who gets a lung infection, to call it as acute on chronic has some challenges. This is more clear when you look at the very recent data of 2022. 622 patients. Those who had grade or 3 ascites, they were followed. About 44% did not have further decompensation, but the others had decompensation. Let's look at it. Now, these patients got a refractory ascites, SBP, HRS, variceal bleed, HE, and they continue to have this second decompensation, third decompensation, and 40% died. Now, Greetings from the Institute of Liver and Biliary Sciences. I am grateful to Professor Dayal and Professor Vijay Shankar for inviting me. I would share some of the new thoughts on managing ACLF and the challenges. There are two definitions and the debate 2% of the patients. While kidney failure was in 18%, lung failure, coagulation, they were all separate. 2 organ failures and 3 organ failures were already present in about a third or 3/4 of the patients. Now, with this definition, without a liver failure, without jaundice, a decompensated cirrhosis may have kidney involvement. Will that call as a ACLF? For example, there is a patient who has got infection and has liver disease. Will that be called as acute on chronic? Let us take the example of chronic pancreatitis. You have a patient with chronic pancreatitis who gets pneumonia. He gets sepsis or he gets AKI. Will you call such a patient of chronic pancreatitis as acute on chronic pancreatitis? Probably no. So this whole concept of having a cirrhosis who gets AKI alone or who gets a lung infection, to call it as acute on chronic has some challenges. This is more clear when you look at the very recent data of 2022. 622 patients, those who had grade or 3 ascites, they were followed. About 44% did not have further decompensation, but the others had decompensation. Let's look at it. Now, these patients got a refractory ascites, SBP, HRS.
Beg an apology. We have some technical glitch. He will be joining us shortly. Since we are having some technical issues with our live stream, may we request our honorable chairpersons to begin with a fruitful discussion.
I'm Dr. Hemant, I'm a nephrologist. I want to clear a doubt. And that doubt is, one perspective where you have a cirrhotic patient with SBP, and another perspective is you have a cirrhotic patient with sepsis. So my question to the nephrologist, learned nephrologist is, we use IV albumin infusion where required in these two perspectives. We should use this IV albumin infusion in cirrhotic with SBP and in sepsis also. That is my point. Whether IV albumin infusion should be used in cirrhotic patient with sepsis or not. I have seen in the books and in the literature with SBP it is very much used. So in sepsis whether it should be utilized or not. That is my question.
All these patients who are in sepsis and not showing SBP and they are cirrhotics, they are already having some amount of the renal dysfunction. So albumin is indicated in all these patients, and this is very helpful.
Do you feel that if we give IV albumin infusion, the organism will thrive on albumin? That's a big question. Whether we are allowing the organism to thrive on the nutrition of the albumin.
No.
Because the BMJ has a lots of
It is just a thought why the organism will thrive on albumin.
just like we use.
No, this is a well-established fact.
That is,
The usefulness of the albumin in the SBP in all sepsis patients presenting with the decompensated cirrhosis and sepsis.
I raise this question only because we have lots of debates on IV iron, use of IV iron and use of IV albumin in septic patients.
IV iron is a different thing. So probably what you want to ask, use of albumin in a patient who has SVP to prevent renal dysfunction, this is an established fact. Probably what you want to ask is, suppose a patient with decompensated cirrhosis comes with say lung infection, chest infection, does not have renal dysfunction at that time. So whether giving prophylactic albumin at that time will prevent renal distress. Probably that is what you want to ask, and this is what Dr. Virendra Singh sir I would request to answer.
In these patients, if you look at this is a patient with the cirrhosis, is having ascites, but not having SBP. In these patients, there will be a hypernatremia, there will be some amount of the AKI, and there is the sepsis is already there. So these patients will be benefited by giving the albumin. This is indicated.
Sir has told, it just like the iron provide nutrition for the bacteria inside the body. So is there any chance of having albumin also provide the nutrition for bacteria inside the body?
No, not at all. This is a wrong concept, and this is a proven fact that the albumin is given in patients with the SBP or preventing any further damage.
My other question, Varinder, you are a hardcore hepatologist, is disadvantage of albumin because of the increased capillary permeability, where it leaks into the lungs, and we have seen patients where the lung hypoxia deteriorates after giving albumin. So we restrict albumin in absence of SBP in patients who have hypoalbuminemia documented.
See, I'll refer you to go through the APASL guidelines. This is a 35-40 page article just published in the Hepatology International. Open access is there, and in that we have clearly given that there is a risk of the pulmonary edema in these patients. So you will have to be very, very careful, and the albumin infusion should be given over a period of 4 hours.
So I think the
So you
concern,
have to be dead slow in infusing albumin in these patients.
concern to us as a gastroenterologist is not bacteria thriving, but as we were discussing that it's a capillary permeability and increased risk of pulmonary edema.
And if the CVP is more than 18, we should never try. If it is between 15 to 18, then you have to be very, very slow in giving albumin in these patients.
Sir, apart from the low albumin in patients with cirrhosis, the albumin is also dysfunctional. So how we assess the quantity of effective albumin?
We cannot.
We cannot. Then how would we decide what should be the effective dose of albumin infusion?
There are various studies in which they have shown that if the albumin level is more than 3.5, so you give albumin. There are different the schedules for giving albumin. Some people give it 40 grams a week, and some people give it 20 grams a week. I follow the 40 grams a week, but it is little costly. And we ideally in that study in which they said that this should be more than 3.5 grams, so we can measure the albumin level. But even if it is not raised more than 3.5, we can keep giving the long-term albumin in these patients with the cirrhosis and ascites.
Sir, as mentioned in ANSWER trial, the the patient survival will be increased only in those patients whose albumin level reached up to the level of 4 gram per liter.
Yeah, this is there in that ANSWER trial, but the other studies also there in which they looked at the various levels, and they said that it is not necessary that the benefit is only when this is more than 3.5 grams. Even when it is not more than 3.5, you should keep giving the albumin. The long-term albumin infusion is helpful.
Any more queries?
Sir, in patients with cirrhosis with ascites, there are 3 scenarios. If ascitic fluid aspiration is done, the total ascitic fluid total neutrophil count more than 250, and in between normal and up to 250, and less than suppose 25 or 50 whatever. So, is there any difference in natural history or probability of developing complications in patient with ascitic fluid count in between intermediate range as compared to normal level ascitic fluid neutrophil count?
See, the normal range, there is hardly any chance of developing the AKI in the patients. So that is out. The question is when this is less than 250 or more than 250 neutrophil count. And in that, the group in which this is more than 250, this is clear-cut SBP, you treat that as per the SBP guidelines. If it is less than 250, then probably these are patients in which either the culture will come positive, or if the culture is negative, then you may have to repeat. If the general condition is not improving, then you may have to repeat the ascitic fluid diagnostic paracentesis, and you will find a raised count in the second diagnostic paracentesis. See, this is not a single item that the SBP is diagnosed based on this is theory, this is fine. But there are other parameters also. See, these patients will have the hyponatremia. Maybe the sodium is less than 130. Then these patients will have a low MAP. The MAP is maybe around 70, 75. And of course the AKI. So the urine output is going down. So if you see all these things, if they are there, then probably this is the patient who is harboring infection. And although the cell count is not more than 250, the neutrophil count.
Greetings from the Institute of Liver.
Sorry. They were asking questions regarding the SBP. Dr. Sareen, please go ahead.
AKI alone, or who gets a lung infection, to call it as acute on chronic has some challenges. This is more clear when you look at that of ACLF, even in the absence of liver failure. Why mix the two? This is DCLD. Therefore, when you look at these two groups of patients, one who have decompensated cirrhosis, who get further decompensated by sepsis, shock, AKI, they are a different group. But when you look at a patient who has chronic liver disease, F3, F4, or has a compensated cirrhosis, but gets an acute insult, and there is only one type, that is, there is liver failure. So this patient has jaundice, followed by ascites. So the jaundice is cell death, which is leading to acute portal hypertension. And this is the phenotype that apostle recognizes as acute on chronic liver failure. Patients who get bleed, coma, ascites, blah, 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 all of them, if you take and count, as per Cliffordism, there are 27 phenotypes. There is no clear inclusion or exclusion criteria. And if you take the US, the Nexel definition, there will be many more such. So what we need to see is a patient of CLD or cirrhosis who gets decompensated by jaundice and ascites. So the definition from west versus east, which definition is clear? Can you differentiate a disease which is distinct from the natural course of cirrhosis? And can you provide opportunity for non-transplant survival? Already two organ failures occur, there will be limited chances. And what are the management options? So APASL R provides you with a clear phenotype, jaundice, ascites, coagulopathy. While EASL and CLIP will provide you with a heterogeneous phenotype. We have learned it in last 1 decade. Now you have to do the severity assessment. Severity assessment starts in CLIP by organ failure. You must have extrahepatic organ failure and a score should be more than 64. Then you go to liver transplant. In ARC, liver failure in a CLD or a cirrhosis. Let's say you have ALF. In a patient of ALF, you say jaundice, coagulopathy, HE. So similarly, here you have liver failure in a CLD and cirrhosis, and it is grade 3, then he goes to liver transplant. So ARC gives you the APSL, ACLF Research Consortium score gives you severity, organ failure and survival outcome. Let's take the CLIP organ failure score. Here, the patient has to get average points of 65 or to say that it is severe disease, you can have these score of 7 or more. You have 6 of these points which will already come. Here you will see that patients will get 6 points without being severe. On the other hand, if the patient has just merely high bilirubin but has nothing else, he will probably not be a candidate for going for liver transplantation. And many of these criteria are making patients extremely sick. In a recent publication by the same group, Jonel Trebeka from the EASL, it says ACLF patients constitute a heterogeneous group with respect to number and combinations of organ failures, etiology and precipitating events. Because of this, if a patient of ACLF, according to the CLIP definition, gets pulmonary failure, lung infection, then your CLIP score gives you only 49% accuracy. Your child score, MELD sodium will give you much better scores. Let's look at the simple ARC score, which you can do at your bedside. A jaundice, coagulopathy, encephalopathy, and lactate, markers of liver failure, and creatinine, marker of renal involvement. Let's look at a patient who has come to you with a bilirubin of 25. He gets 3 points. He has no HE but gets 1 point. INR is above 2.5. He gets 3 points. Lactate is high. Creatinine is high. Such a patient will have 3, 12 and 1, 13 points. He is a very sick guy. He may not have that amount of high creatinine. You see that in the CLIF definition, you require a creatinine of more than 2 to start with, while in the ARC score, you start with less than 1 creatinine and more than 1.5, not 2, is still very high. So how do you grade ARC? The liver failure in a cirrhotic is grade 1, 2 or 3. If it is 11 to 15 as in the case shown above, is grade 3 liver failure. What is the natural history of grade 3 liver failure? So score is above 11, 12, anything. Then you have a mortality from 11 to 12 in 1 week, 20% mortality increases. But if the score is less than 10, 1 unit increase from 8 to 9, only 4% by day 4 and 5% by day 7. So a patient who may have a high bilirubin but may not have a score above 7, he can still be doing very well for you. So this is the simple bedside score by which you can prognosticate your patients. Now another new definition, a new addition in the last year is how do you predict organ failure? In very large study of 1600 patients, if the mean arterial pressure is less than 80, 76% of these patients may have problems. But otherwise, just ascites will not. If the patient has an albumin of less than 2.8, he is a very high risk patient. So how do you define a MAP which is less than 79 or an albumin which is less than 2.8? Another important way is of handling patients with starting with creatinine. If the creatinine is less than 1.5 but his INR is high, coagulopathy with renal involvement, he has 63% 30-day mortality. But if the creatinine is more than 1.5 and he has circulatory failure, blood pressure goes down, MAP goes down, 30-day mortality is 90%. So these are simple bedside definitions based on the simple ARC score, create and MAP. So let me summarize what we have learned in last decade. Two definitions, liver failure centric, which drives organ failure, first the liver, then the kidney or other organs, is based on a process. And it does not need to define ACLF, extrahepatic organ failure. While the EASL definition, CLIF definition requires that you must have other extrahepatic organ failures, and sepsis drives organ failure. Diagnosis is often late, often non-transplanted. The assessment score ARC about 10, grade 3 LT, CLIF 2 or more organ failures, then and score of above 64 LT. AI-based scores, as I showed you, can predict survival better. So let me summarize. ARC ACLF is a clear phenotype. CLIF is same as rapid worsening of a decompensated cirrhosis. New management options and challenges in last 3 years. First is, how do you feed your patient? Can you give fat to a patient who has a bilirubin of 20? And what happens to albumin which you keep pumping? So the nutritional prescription that we proposed in 2019, 35 to 40 kilocalories, about 80 kilogram patients, you should have 2,600 calories diet. You can give by nasogastric tube. 30% is fat because fat is what is absorbed for and beneficial, and it changes to a positive nitrogen balance. So you can give full fat. Proteins, multiple meals, and sometimes intravenous fats and vitamins. Now, can you give intravenous lipids like intralipid or so? Yes. So this study published 2 years ago, bilirubin of 16, MELD of 25, the intralipid was given for 3 days, no adverse event. What is interesting is these patients before lipids had a negative nitrogen balance, catabolic, but after 3 days they became positive nitrogen balance. Albumin in patients with ACLF is dysfunctional. First, there is decreased synthesis. Second, there is a endothelial injury, so the albumin dysfunctional causes vasodilation and it causes more immune injuries. The albumin changes to nitrosoalbumin, which is a vasodilator, and coagulation are deranged, and abnormal HNA1, HNA2 albumin prototypes are really very, very toxic. Now, in a normal person, one molecule of albumin, this heart-shaped structure is albumin, one molecule of albumin binds to one bilirubin. However, in patients who have got ACLF, one albumin binds to three bilirubin molecules, and this leads to a state where albumin cannot do anything, it cannot bind to other things. This is a dysfunctional albumin, hyperbilirubination. So this albumin, the moment you give extra albumin from outside, there will be a problem. So therefore we should probably remove the albumin rather than keep, and we should therefore have new modalities of dialyzing this albumin. I will now briefly touch upon acute portal hypertension syndrome. The patient with cirrhosis already has raised portal pressures. With the acute injury, let us say of drugs or autoimmune or alcohol, there is a sudden rise in portal pressure because cytokines release, stellate cells are active, endothelial dysfunction, vascular relaxation is impaired, and increased bilirubin causes a vasodilatory effect and reduced MAP. So sudden rise, let's say from a pressure of 15 HVPG, it becomes 20. Therefore, patient gets ascites. HRS may bleed or go into HE. So what should we do? In a ACLF patient, high portal pressure, we should not do paracentesis of 5 liters. We should do a modest volume paracentesis of 3 to 4 liters. These patients have very high plasma renin and abdominal pressures are very high. In this study published few years ago, if you have patients of ACLF with grade 3 ascites, do small volume taps and you must give albumin slowly to these patients. Then PICD is seen in 27%. If you don't give albumin, 62%. Still there is a lot of patients who will get PICD. So slow decompression is much better. Variceal bleed. The portal pressure is suddenly high, I told you. So if you give in these patients beta blockers, you can reduce the mortality. So given carvedilol versus placebo in 28 days, there was an improved survival. You can use propranolol because carvedilol can cause more hypotension, HRS. I suggest propranolol is better. Kidney injury. There are two types of kidney injuries which can occur. One is functional, which you normally know is HRS, AKI, but it can be non-responsive to volume. But what is worrisome is in patients with ACLF, a rapid onset of ATN, bulimic injury, and if the patient already has diabetes or other like alcohol, you can have CKD. Albumin, if you gave it early in patient with ACLF versus no albumin, there is a benefit, it reduces incidence of AKI. How should therefore we manage our patients? Newly diagnosed AKI in ACLF, first give volume replacement, then give albumin. If there is an improvement, continue, but don't overload. If there is no improvement in 48 hours, which now we are changing to 12 hours, you can start vasoconstrictors. Only 1/3 will respond to terlipressin, 2/3 may not. Therefore, you may be ready for the renal replacement therapies in these patients. Now, this study by Ankur showed that terlipressin non-response, if occurs, these patients' survival is poor. If the patient 1/3 only will respond, if they respond, they improve. If they don't respond, they may die. The subsequent study by Dr. Arora, it shows that terlipressin is superior to noradrenaline. So here is terlipressin response, here is norad, and therefore we should first drug of choice is terlipressin. But the response is only in 1/3 or 40% of the patient. This is day 4, day 7. Terli does better than NORAD. Now this was presented last year in the plenary. Why should you wait for 48 hours? This is the early study in which if you do early terlipressin, that is at 12 hours, not 48 hours, the response could be better compared to standard therapy. So now I'll briefly touch upon infection, achieve very little data, and role of bridge therapies. Remember the SIRS, the cell death due to hepatic injury causes the intense inflammation, let's say alcohol or delete, there is a hepatocellular injury, that is the driver for SIRS. And the SIRS leads to development of sepsis and neutrophils, monocytes, T cells and DCs have impaired response. So if a patient with ACLF comes, this is the study by Dr. Kulkarni, if you give norfloxacin in the beginning compared to placebo, there is an improved response and the transplant-free survival was 77% compared to 64%. It shows that you can prevent SIRS to go to sepsis by prophylactic antibiotics. There are some bridge therapies you are fully aware. One of them is plasma exchange. Now plasma exchange helps us in many ways. It eliminates toxins, stimulates liver regeneration and causes immune homeostasis. The therapeutic plasma exchange gives you a window of a week or two for transplant. Compared to very expensive Mars or Fresenius, plasma exchange is superior to FPSA as far as organ failure or survival is concerned. Lastly, I will try and touch upon a very new paper of alcohol-induced ACLF. Now, commonly you give steroids, but see carefully in this study, which is a large multinational study. If you give steroids compared to placebo, there is a reduction in MELD score by about 4 or 5 at the end of 1 month. But by 3 months, they are same, and by 6 months, no difference is there. So steroids only give you reduction in MELD by 4 at the end of 1 month. But if a patient has ascites, jaundice, and has high INR, that is our ACLF, there is no single study. So this is a large database from ARC. It shows you first, only 30% of the patients of ACLF are eligible. Others have kidney or infections problems. Now of those who are eligible, response rate is seen in only about 44% of the patients. The rest are all non-responders. So 40% of 30%, you can imagine only 12 to 15% of total population will be steroid responsive. So can you decide why should you give everybody steroids of alcoholic hepatitis with ascites? So just do an ARC score. If your ARC score is up to 10, there is a benefit. It reduces death. But if ARC score is 11, 12 and above, hazard of death increases. So simply calculate ARC score. Steroid responsiveness, if the ARC score is up to 10, the patient will be responsive. If the ARC score is above, he will be non-responsive. So mortality and steroid response, ARC score is the best. Now early predictors of non-response and flare of autoimmune hepatitis. When you look at the new Surfasa score and others, you can also say if the ARC score is above 7 and Surfasa is above 1.2, mortality, the probability of survival is very good. Liver transplant is the final savior. Timing. First aim is to convert non-transplant into a transplantable patient. And this is what is published. First week is the crucial period. Now here is a study of 1,000 patients of ACLF. At the time of admission, eligible for liver transplant were 34. But during hospital stay by day 4, one could make 63% eligible for transplant. And by day 7, 61% were eligible. If you wait long, may not be. So our aim is day 0 to day 7 to decide. Now if you use the CLIF definition, EASL definition, and use grade 1, grade 2, grade 3 based on organ failures, you will see this large US database. When they wanted to transplant, concordance between 3 US centers, whether it is ACLF2 or ACLF3, was hardly 50 to 60%. They could not transplant because they could not place them into grades based on ACLF using CLIF criteria. ARC makes it very simple. So the way forward is proper categorization and selection. So who is not a good candidate? Our aim is if you transplant, patient must survive 5 years, 50% chance. An active bleed, an untreated sepsis, fungal or PDRs, PaO2 to FiO2 is less than 150, so that's a bad lung. He's on NORAD, which is high, lactate above 9, 3 organ failures, poor quality graft, 3 ICU. So this is the management of ACLF. I propose that a patient comes at day 0, assess his ARC score and MELD score. If the patient has sepsis, at any time optimize and prevent organ failure, you may use a plasma exchange, steroids or growth factors. But if the ARC score is high, then don't wait, straight transplant. If the patient is waiting, the donor is being screened, and by day 4 to 7, the ARC score improves, comes down from 10, you may actually plan medical treatment. But if it is increasing or not changing, emergency transplant. If you are using CLIF or European definition, already patient has 2 organ failures, the first thing will be to give plasma exchange, stabilize, let him improve, and then take for emergency transplant. But if he already is not improving or has 4 organ failures, multi-organ failures, then you can only give supportive care. If you have this simple thing in mind, you just need to remember ARC score 10 or above, and then you can manage your patients very well. Join ARC, Bihar, Jharkhand, they are huge populations. ARC has 9,700 cases with 78 centers. You are more than welcome to join, and I do hope collectively we can make a huge difference in our approach to patients with ACLF. Thank you for your kind attention. I wish I was there in person, but my best wishes to you for the success.
Thank you everyone for your involvement. Since we have already had our discussions, we mark the end submission of our first session. I would like to request our chairpersons sitting on the dais to present a memento of appreciation for our speakers. Please come forward and join in for a short photography session.
I'd like to thank Professor Dayal and Dr. Vijay for giving me this opportunity. And it was heartening to come here. I studied in Ranchi. Dr. Ramesh Chandra, I considered one of my teachers. It was also, I was glad to see Professor Ramesh Kumar, who is a dear friend and colleague of mine, and one of the astute and brilliant hepatologists I have ever seen. So I have given 15 minutes to talk on loco-regional as well as systemic therapy. To do this impossible work, I will really have to go fast, so please pardon me for that. So this is the schema of presentation. Very briefly talking about BCLC staging and ISGCON modification, which is under publication. A loco-regional therapy in advanced HCC, alone or in combination. A proposal for systemic therapy, first line and second line. Upcoming treatment I will not be discussing, and summary. So we all know from this paper from Lowlet that basically we use BCLC staging. Almost all medical oncologists or practicing hepatologists use that because it is not the best, but it is the easiest to use. So we have a divided HCC in a 5 major category: very early stage, stage 0, A, intermediate stage, that is B, advanced stage C, and terminal stage D. The treatment of loco-regional therapy is basically limited to the intermediate stage and a part of advanced stage, and the systemic therapy mostly to the advanced stage. So this is the INSL modifications of the updated BCLC staging, where the stage B has been divided into B1, B2 and B3. The B1 is an area where it is an intermediate stage but having an extended, comes within the extended liver transplant criteria. So you can do a TACE or tear to preferably down staging, so you can go for transplantation. Stage B2 is well-defined nodules with a preserved total flow with selective access. So TACE, tear or with or without SBRT can be done. And if there is a progression, you can do systemic therapy. The stage B3 is a diffuse, infiltrative, extensive bilobar liver involvement. We have proposed that if you can do radioembolization, if feasible, should be done, followed by systemic therapy. The stage C is basically the advanced stage where it has been divided into 2 groups, C1 and C2. It was not there. It has been proposed that if there is a portal vein thrombosis but no extrahepatic disease, it should be called C1, and stage C2 is disease having extrahepatic disease. Ma'am has already discussed about RFA, microwave ablation. She has not brought the IRE, but I am not going to do that because my area is only for the advanced stage. So I will very briefly talk about transarterial chemoembolization. Ma'am has already spoken elaborately, and transarterial radioembolization, and very briefly about radiation therapy. Ma'am has already gone about how the TACE is done. It's a minimally invasive procedure. Catheter threaded into the hepatic artery, delivers chemotherapy followed by embolotherapy. Last dose of chemotherapy, mostly doxorubicin, mitomycin or cisplatin, depending on the institutional protocol you use. The advantage is embolization stops chemotherapy washout to concentrate in the intratumoral but not systemic chemotherapy exposure. So the tumor gets chemotherapy, the other systemic toxicity of chemotherapy is saved. Arterial embolization achieves the partial response of 50 to 55% of patients and significantly delays tumor progression. So Forner et al. In this paper has proposed who are the case for TACE, HCC were confined to liver with no extrahepatic spread, child to gay, compensated. There is controversy about bilirubin cutoff. I am not going to do that. Usually we do it 0, 2 and then 6 months. We generally can repeat it, still stabilization or regression. Now does TACE help? Yes, it does. Meta-analysis has done. I have 7 randomized RCTs. The 2-year survival drafted between 20 to 60% with a median of 41%, and the treatment response between 16 to 60%. Average sessions has been seen 1 to 4. There are of course some risk of infection, tumor lysis syndrome and hepatic failure, but with expert hands the risks are less. You can do a bland embolization, you can do a conventional lipidol TACE, and also you can do a drug-eluting bead TACE. There is no, RCT has not shown any superiority of DATE TACE. There is also an evolution of conventional TACE technique from selective to supra-selective to ultra-selective. So you can, the extent of tumor necrosis increases and the side effects decreases with the level of TACE selectivity. There are of course a contraindication of TACE. Absolute contraindications are decompensated cirrhosis, extensive tumors involving entire both lump, portal vein thrombus, and there are related contraindications like esophageal varices, large tumor of more than 10 centimeters. So if you, from a medical oncology perspective, if you look at a practical considerations, I would say this is my perspective: liver only, beta maximum size of less than 10 centimeter, childhood A, B7 without ascites, number of treatment 3 to 4 per year, technique supraselective, either conventional or depth test, expected response 50 to 60%, treatment related rate 1 to 2%, median survival between 20 to 40 months, and treatment failures if there is absence of response after 2 treatments and progression, then don't do that. But what happens when you have a main portal vein thrombosis? You can't do TACE because it will lead to massive liver damage. That's why you can TARE. Ma'am has already spoken. You use yttrium 90. It's a pure beta emitter. The goal of TARE is microembolic, preserving blood flow. So unlike TACE, you actually preserve the blood flow so that targeted liver segments get in radiation therapy. Through the hepatic artery, radioembolic microsphere is used to TARE, deliver the isotope yttrium 90 to the liver tumor where they lodge in the arterial level. So what is the advantage of radioembolization? It may improve the time to tumor progression, less fever sessions, no post-embolization syndrome, may be safer in advanced disease with portal vein thrombosis, and radiation segmentectomy may be curative, and future liver remnant hypertrophy from radiation lobectomy can provide tumor control, which ma'am has already very nicely shown. Now, TACE versus TARE for patient with HCC, there is a meta-analysis published last year, which shows that current data suggests that 2 treatments do not significantly differ in terms of overall survival in both overall and individual patient level meta-analysis. However, TARE provides a significantly longer time to tumor progression than TACE, and provides a safety profile also favors it. I will briefly touch upon radiation therapy, not because I am averse to that, but because of large RCT data are unavailable, and I could not gather sufficient data to follow that. So it is a radiosensitive tumor at higher dose, but also the liver is a radiosensitive organ, so toxicity is also easily achieved, and complication of liver failure can make treatment planning difficult. It can be a palliative radiation, not used nowadays much. Definitive radiation, SBRT, mostly used. 3D CRT, image guided radiation, and charged particle therapy, which mostly used in Japan. SBRT versus RFA has shown similar benefits, and there are trials going on, and we are using SBRT in many cases. I will briefly come up and I will discuss the INSL guidelines. Of course, there are combination therapy like TACE with RFA, TACE with microwave ablation, and TACE with systemic therapy. Now, what is the reason for using TACE with systemic therapy? Because in the treatment of intermediate stage, post-TACE, there is progression is frequent, and we know that angiogenesis play an important role in tumor survival after TACE. So it has been proposed if you use an anti-angiogenic tyrosine kinase inhibitors, they may improve over and above only TACE. So there have been 2 trials, tactics trial, which use TACE alone or TACE with sorafenib, and they have used first sorafenib followed by TACE, and then again sorafenib and multiple TACE. If you look at this, there was a numerical superiority of the combination therapy over TACE, both in PFS as well as time to tumor progression. And this is the updated results. They showed that median OS was 36 months versus single agent was 30.8 months, sorry, not 308 months, sorry for that. And the median PFS was 22 months versus 30 months. So they concluded that overall survival in combination arm, although numerically superior, did not reach statistical significance. And PFS in the combination arm was significantly better. The major reason why OS data did not show superiority in the combination arm was speculated and suggested that because the other arm got multiple second, third or fourth line of treatment, so ultimately the OS difference was not there, and most probably OS is not the best endpoint, and we should look at PFS. And also last year there was this trial from China, lenvatinib with TACE, where TACE with lenvatinib was randomized with lenvatinib alone, and the primary endpoint was overall survival and secondary endpoint was PFS. It did show that overall response rate and disease control rate was higher in the TACE category, and the final result, which was published in JCO last year, shows that median overall survival was significantly longer, and median PFS also was superior. So concluded the addition of TACE to lenvatinib improve the clinical outcome and in the potential first-line treatment. So this is the INSL guidelines for the local region treatment. This is still under publication. So I'm glad that they allowed me to show this. So HCC patient in intermediate B2 and preserved total blood flow with defined tumor burden should be considered for intra-arterial local regional treatment. The use of yttrium-90 TR in such patients should be individualized. Combination case with ablation of HCC more than 5 cm case may be combined with microwave ablation rather than RFA. Patient with INSL B3 recommended treatment is systemic therapy. However, TR can also be demonstrated as to improve survival. HCC patient in advanced stage with portal vein thrombus without extrahepatic disease should be considered for TR, especially if downstaging is planned. SDRT is an option for patient with intermediate stage HCC, which in stage B was not surgical candidate and could not undergo test care, or who have residual recurrent disease following test care. SB can provide local control. It is also an option for patient with advanced stage HCC with portal vein thrombus, and it provides a survival advantage. For a patient of C1, they may be considered along with systemic therapy. Now I'll have to very briefly, how much time I have? 3 minutes. I'll be very briefly go about the systemic therapy. This is the 2023 criteria. The first line therapy is atezolizumab plus bev and tremelimumab with durvalumab. Sorafenib, lenvatinib has now come to the other recommended category, and the second lines are regorafenib, cabozantinib, lenvatinib and sorafenib. So these are the 4 major studies which has made these 4 drugs or drug combination as the first line. SHARP trial, Reflect trial, IMBRAVE 150 which I discussed in a little detail, and Himalaya trial. We all know about SHARP trial. About in 2008, this paper by Lolet really changed the way HCC, advanced HCC is treated. This is the first drug which shown some statistically significant and clinically meaningful evidence that medicine can work in HCC survival. And the SHARP trial did show that about 8.7 months of sorafenib versus the placebo was 7.9 months, and it became standard of care for almost a decade. But any gastroenterologist or hepatologist or medical oncologist used sorafenib know it's a toxic drug, lot of hand-foot syndrome, lot of fatigue. It was not a great drug, and hardly 10% of our patients actually use the 400 milligram BD, that is the prescribed dose. This changed when Reflect trial came in 2018, and it showed that lenvatinib, which was actually a non-inferiority trial against sorafenib, and has found to be that it has a better progression-free survival and an equivalent overall survival, but most importantly a better side effect profile. And with time it became the standard of care for us. We changed sorafenib to lenvatinib. So the conclusion was that sorafenib improved survival and lenvatinib was non-inferior. By this time we have now come to know our knowledge in the lab and has grown, and we have now known that inflammation and immune pathway plays a big role in the development of HCC. And we also know that exhausted T cell dysfunction, which leads to chronic infections and cancers, which is the same with HCC. This leads to use of immune checkpoint inhibitors, which became around 2000, for which James Allison got Nobel Prize. And we are using it in other cancer and show quite a good result. So initial study was Checkmate 459, which although showed a numerical superiority but did not reach the statistical threshold. But IMBRAVE 150, which is used in atezolizumab with bevacizumab, which is a combination of anti-PD-L1 monoclonal antibody with anti-VEGF monoclonal antibody, did show an overall improvement. And also there is another drug called durvalumab, which is an anti-PD-L1 with an anti-CTLA4 monoclonal antibody, also did show overall benefit. There was also some failure, like pembrolizumab and lenvatinib did not reach the statistical endpoint. So is the cabozantinib with atezolizumab. Also in a particular subgroup, 2 immune checkpoint inhibitor, nivo plus ipi, did show some benefit, and trial is ongoing. So this was Checkmate 459, nivolumab versus sorafenib. Although there was numerical superiority on nivolumab, but the predefined statistical endpoint could not be reached, so we call it a failed trial. But this is a NEJM paper by Richard Finn, which changed the way we try to treat and has made atezolizumab plus bev as the first line of drug. So it is a 2:1 open label RCT of atezolizumab 1200 milligram and bevacizumab 15 milligram versus sorafenib. And it also took the high risk patient which hitherto were never taken into trial. I just need one more minute. So ultimately both the PFS as well as OS was improved. But the most important thing you must understand looking at this forest plot that atezolizumab was superior in all respect, but in HCC due to NFLD, it did not show that good result. So nowadays for NFLD, we are not using atezolizumab HCC due to NFLD, we are trying to use the TKI instead. The toxicity also was different. For atezolizumab, it's a bleeding, hypertension and was more the serious side effect. So they concluded that atezolizumab highlighted the benefit of targeting multiple steps. At the same time, Himalaya trial also did show that durvalumab plus tremelimumab did have superiority, and it has become another standard of care. Although tremelimumab is not yet available, I am told that they will be coming the next month. So these are the 4 major studies which have shown. So as of now, atezolizumab plus bev for patients who can afford this has become a standard of care. But most of our patients in a country like ours cannot afford this. So lenvatinib has still remains the treatment of choice for most of our patients.
Sorry.
I will just finish. So this is the. I'll just take one slide for summary of this trial and I'll just. So this is that IMBRAVE has shown that atezolizumab has improved OS, and Himalaya trial has also shown that tremelimumab and durvalumab. These are the second line trials, the cabozantinib, nivolumab, pembro, and these are the FDA approved trial for that. And so this is the final consensus statement for INSL. Sorry, I just.
So thank you very much, Dr. Panda.
I just do the summary conclusion. Can I do that? So I would suggest that hepatocellular carcinoma is a malignant with high fatality. It is a somewhat preventable disease. Underlying liver pathology makes the management challenging. Multidisciplinary approach is the key. In stage B and C, locoregional therapy alone or in combination can improve survival. Locoregional therapy also downstage tumor to make them eligible for transplant. Treatment options in advanced stage is expanding. The introduction of immunotherapy in the frontline setting, in my opinion, is practice changing. Especially the immunotherapy with anti-VEGF monoclonal antibody remains the first line. However, not every patient will be a candidate. In a resource-constrained country, I think TKI will still remain a treatment of choice. And they consider TKI or single-agent immune checkpoint inhibitors in those patients. Recent data from single-agent TKI also demonstrated a very improvement. And of course, universal vaccination, awareness and transmission research. Thank you. And this is the INSL team for the first time. I think one of them, Professor Anil Arora, is here. I thank the organization.
Thank you, sir, for your insights on the topic. We now hereby are open for the discussions on the topic, and we also like to invite queries from our listeners. We request our chairpersons on the dais to set about the discussion.
Thank you, Dr. Panda and Dr. Goenka, for the very comprehensive discussion on the topics that you were given. I request questions from the audience, from the floor.
My question is to Dr. Usha. Excellent presentation. You said in multicentric HCCs you showed one of the good response to TACE. Is there any point of doing TACE for one lesion when you have lesion in both lobes? Leaving a rest unattended, does it help?
Hi, so if you have from 3 to 5 lesions, they can be safely treated by the ablative technique. If you have a couple of lesions, as I showed, they were coming in the arterial supply of the same artery, but they were different branches. So as Dr. Panda said, we super selectively cannulate those using microcatheters and guide wires and embolyze all. We don't like kind of leave them. If at all, if at all 1 or 2 lesions are left, we would do ablative technique subsequently. Like it would be a combination for that.
Yeah, and second question is to Dr. Pan, Dr. Pan. And so many patients come to us with laminectomy failure. Our oncologist says now you cannot use atezolizumab and bevacizumab. Is that right?
No, that
Can
is not.
that be used as a second line?
No, so I could not show the INSL consensus. So that is not right. Yes, the atezolizumab plus bevacizumab is first line, but if your patient cannot use for some reason and use TKI and there is progression, if there is no other contraindication for immunotherapy, you can use either a combination of immunotherapy or a single agent immunotherapy. In fact, pembrolizumab data I could not show, that is in the second line. Also, there are other drugs like ramucirumab, which is an anti-VEGF monoclonal antibody. There is also a combination of immunotherapy. So it is not that, but they say if you want to use immunotherapy, it is preferably to be used in the first line, but there is no major contraindication of not using that unless there is other contraindication.
And second, autoimmune related HCC is another contraindication for atezolizumab.
So liver transplant, post liver transplant or any autoimmune disease are absolute contraindication. We have lost patient in other cancer with acute autoimmune disease. So post transplant there is a reported data of 30% liver transplant graft failure. So that's an absolute black box warning of not using.
Can we please ask the questions for the other session? See, this is a patient who has undergone a case and then successfully treated. There is no remnant, but after about a month or so, the alpha fetoprotein is going up. And we followed this patient after 3 months. There is no localization of the tumor. The alpha fetoprotein is further going up. And for 6 months, again, there is no visualization of the tumor anyway. So what to do in such patients?
That's a very good question, sir. And there is no right or wrong answer, but as of now, we do not treat a biochemical rise in alpha fetoprotein. For the very simple reason, then the follow-up of once you give the treatment, only basis of alpha fetoprotein you cannot follow up. If you have a target lesion, you know that is shrinking. So only biochemical. Even similarly like ovarian cancer, you do not treat a rising CA125 patient. Even if you know most probably the lesion will come. But as of now, I do not think, I think with a close observation would be the treatment of choice. Of course, there may be a point of difference, but
patient raised a genuine question. My alpha fetoprotein is going up and you are not doing anything.
So can we short the discussion while you are on
Thank you, speakers, for nicely demonstrating the cases. One question I would ask from the professor regarding the first case, you showed that it was type 3 hydatial where there were a lot of membranes in the cavity and you evacuated everything. But this is actually not the protocol. The pair is indicated only for the type 1 cases where all the content is.
No, I think I clearly showed the guidelines which are there at this juncture. As of today, 3A and 3B can also be treated by pair very successfully. So it's only the ones which are inactive which don't require it.
I'm happy to say you that another audience that we are following almost all procedures in Bihar, including tips and tips. More reference we are getting for tips actually, not for the tips. And we are getting very good results.
Thank you everyone for your involvement. We would like to request the chairperson sitting in the dais to please present memento of appreciation to our speakers. May I now have the honor to invite our chairpersons for the next session of the day to come up on the dais. Dr. Shahbaz Duha, Senior Consultant Physician in Patna. Dr. Sanjeev Kumar Thakur, Senior Consultant Gastroenterologist in Patna. Dr. Chandan Kumar Singh, Consultant Physician in Purnia. Dr. Ravikant Kumar, Consultant Gastrologist in IJMS Patna.
We are now the honor to invite our speaker for the session. topic, Dr. Parveen M. Rathi, Professor and Head of Department of Gastroenterology, Imperial Rare Hospital and PS Medical College, Mumbai Central, Mumbai. Before our senior publications, he has been extensively involved in research work. His area of expertise includes therapeutic biliary work, therapeutic abyss, GI and colonoscopy. His topic for today's discussion is how to manage MASLD. We request him to kindly begin with his topic.
What I'm going to do over the next 15-20 minutes is to give a brief overview which includes the introduction of the topic, changing trends in the epidemiology, changing trends in the Indian scenario, the variant of NASH.
Mike, please.
About the diagnosis of the NASH, the management strategy, the new drugs, and the new So NAFLD currently affects about 25% of the global population, and about 60% of the patients with type 2 diabetes mellitus are affected by NAFLD. The WHO recommends a lower BMI cutoff for those of patient ancestry that is less than 23, with obesity more than 27.5 kg per square meter. Yeah, and the prevalence of NASH is an estimated about 1.5 to 6.5% in the general population, and 37% of people are with type 2 diabetes are affected with NASH. And the prevalence of NASH is expected to increase by 63% between 2015 and 2020. It is estimated that 7 to 20% of individuals with NAFLD have a lean body habitus. Now, what's the scenario in India? NAFLD in the general population in India varies from 9 to 53%. There is a rural-urban differences in the prevalence. And the prevalence of NAFLD among patients with type 2 diabetes is around 56%. A recent meta-analysis has reported NAFLD prevalence to be around 38.5% in adults and 35% in children. And this graph shows the geographic prevalence in different parts of India of NAFLD, which varies from 8% to as high as 53%. Now, coming to the spectrum of NAFLD, on one end is a non-alcoholic fatty liver disease, on the other end-stage liver disease complications like decompensated cirrhosis, and a small proportion of patients may develop SCC. So what is NAFLD? The definition is very simple. If the steatosis is more than 5% of hepatocytes, so if the liver fat is there in more than 5% of the hepatocytes, then that is NAFLD. Now, excessive hepatic fat accumulation is associated with usually insulin resistance, and one has to exclude the secondary causes like alcoholic fatty liver disease and other causes of fatty liver. So NAFLD, that is non-alcoholic fatty liver, comprises pure steatosis, and they could be associated with lobular inflammation. And intermediate stage is a NASH, that is non-alcoholic steatohepatitis, which again could be associated with early fibrosis or intermediate stage of fibrosis or late fibrosis, that is F3, F4, which can lead to cirrhosis, and a small proportion can decompensate and develop hepatocellular carcinoma. So what is the natural history of the disease progression? A recent meta-analysis demonstrated that once the fibrosis sets in or patient has a non-alcoholic steatohepatitis, then these are the primary predictors of disease progression. So from non-alcoholic fatty liver to steatohepatitis and end stage takes a long time, but once there is an inflammation and there is a fibrosis, the disease progresses very rapidly. So earlier meta-analysis of a cohorts of patients with non-alcoholic fatty liver demonstrated NFLD fibrosis progression rate of about 1 stage per 7 years, whereas in NASH, the 14 years for those with
NFL. Among patients with cirrhosis, the progression to clinical decompensation, it ranges from 3% to 20% per year. So with each unit increase in the liver stiffness or fibrosis, there is an associated increased risk of 11% of development of hepatocellular carcinoma. So this is a slide which shows that approximately after every 2.5 years, there is a risk of a rapid progression of the disease. So from F0 to F1, F1 to F2, F2 to F3, F4. So it takes about 2.5 years to progress from one stage to other stage. And 1 in 5 eventually end up with cirrhosis. So cirrhosis NASH has emerged as the most common cause of cryptogenic cirrhosis and the SCC worldwide today. The etiologies of SCC in Asia also is undergoing a transition. There is a paradigm shift. When we were students in 80s, 90s, there was a lot of talk about HBV, HCV, and now there is a talk of NAFLD because it is the leading cause of decompensated liver disease and hepatocellular carcinoma worldwide, not only in the Western world but also in Asia. So now there is a change in terminology from NAFLD to MAFLD. So why is there a change in terminology? Because NAFLD doesn't reflect the current understanding of the disease, and a more accurate term would be a metabolic associated fatty liver disease. So this modification of NAFLD to metabolic associated fatty liver disease highlights the role of metabolic factors in the disease etiology. It helps in better understanding of the disease. It facilitates patient-physician communication, and also whatever little public health resources allocations are there, so the importance of public health intervention in prevention and management of this disease. So MAFLD coexisting with other liver disease is defined as dual etiology fatty liver disease and is highly prevalent among all causes of liver disease, as I told you earlier. The Asia Pacific Association, that is APASL, has adapted this term, metabolic dysfunction associated with fatty liver disease, as the new definition. So how do you make a diagnosis of NAFLD and how do you make a diagnosis of MAFLD? The NAFLD diagnosis is made if there is a hepatic steatosis, where there is no excessive alcohol consumption, no other cause of viral disease, no other cause of liver disease like viral etiology, autoimmune hepatitis. Whereas MAFLD diagnosis is made if there is a hepatic steatosis plus one of the following criteria, like patient is obese, or patient has a type 2 diabetes mellitus, or there are at least 2 metabolic risk abnormalities, like the waist circumference is high, patient has hypertension, hypertriglyceridemia, dyslipidemia, CRP inflammation, or high insulin resistance by HOMA. So what is the impact of change in this classification and diagnostic criteria from NAFLD to MAFLD? The prevalence of NAFLD and MAFLD were 37 and 39% respectively in North American population in one study, and even in Southeast Asia, it was found to be 28 and 37% in Korean population. A small proportion of patients who have NAFLD will not meet the criteria of MAFLD, and they can be termed as non-metabolic, non-alcoholic fatty liver disease. The difference between the severity of the liver disease in NAFLD, MAFLD and non-metabolic NAFLD is not clear. A recent Chinese study found that MAFLD was associated with worse renal outcome as compared to non-metabolic fatty liver disease. So what are the benefits if you change the terminology from NAFLD to MAFLD? So as I told earlier, there is an increased awareness of the disease. It emphasizes the metabolic contribution, importance of lifestyle changes, and highlights the preventable and emphasizes the need for appropriate resource allocation and effective public health policy decision making becomes easier. But what are the barriers if you change the terminology from NAFLD to MAFLD? So as there are proponents, there are also people who oppose this terminology because the MAFLD definition does not adequately account for genetic cause for steatosis. It does not resolve many of the ambiguities which are present in a NAFLD classification, and the risk stratification doesn't improve if we change the terminology from NAFLD to MAFLD. The variant of NAFLD is a lean NASH, and lean NASH is said to be there if the BMI is less than 25 per kg per square meter body area. The lean individuals with NAFLD should be evaluated for type 2 diabetes, dyslipidemia and hypertension. And lean individuals with NAFLD
should be risk stratified for hepatic fibrosis. So this cartoon shows a patient who is a lean NASH, that is BMI is less than 23, and those who have a non-lean NASH. Now, why is it important to distinguish lean NASH from, or what is the clinical significance? The lean individuals who have a NASH have a high LDL, and metabolic syndrome like diabetes and hypertension is more prevalent in them as compared to those who have non-lean NASH. The lobular inflammation is more, whereas steatosis and fibrosis is less in lean NASH compared to non-lean NASH. Whereas advanced fibrosis and increased risk of CVS related mortality is higher in the lean NASH compared to non-lean NASH. So this is a cartoon again to show you or depicts the associated risk factors which go hand in hand with NASH, like elderly people, those who have sedentary lifestyle, obesity, hypertension, thyroid dysfunction, and PCOS. Again, the risk factors, there is the integration of public health measures for NAFLD into India's national program for NCDs. Now, all medical colleges will have these corners of non-communicable diseases, where at one corner the relatives of the patient or patient can undergo screening for hypertension, diabetes, dyslipidemia, fatty liver disease, associated malignancy, and the cardiac problems. So at community level, there can be population-based screening for risk factors for non-communicable diseases, and these patients should be referred to high-risk individuals should be referred to a higher center. At primary health center, where the incidence of NAFLD is said to be 1 per 30,000, you can identify the individuals who have suspected NFLD, and they are referred for evaluation of clinically significant liver fibrosis and management of NAFLD to the higher center. At community health center, there could be incidence of NASH of about 1 per 1 lakh population, and once the diagnosis of NAFLD is made, either by non-invasive tests like APRI or FIFO score, then they are risk stratified and then sent to a higher center. At a district level hospital, then these patients can be managed and then can be referred to still higher center if they have got an end-stage liver disease or SCC. What are the genetic factors? The genetic factors, they impact the hepatocyte lipid handling. There are many genetics, these things have been studied, but the 3 important markers are PNPLA3, TM6SF2, and MBO87. This is a study which we did at our center. It was a cross-sectional study, and the parents of probants with NAFLD and without NFLD was screened with abdominal sonography, anthropometry blood test, and transient elastography fibroscan, and PNPLA3 polymorphism. And the screening, what we found that the screening of parents of individuals with non-alcoholic fatty liver disease will help in the identification of undiagnosed NFLD and other metabolic risk factors. One can predict the occurrence of NFLD in the next generation, and we have devised a score that is goes by the name NFLD 16 score. So a guy who is genetically predisposed, who has a sedentary lifestyle and who consumes a high fat diet, there could be increased lipolysis with increase in the free fatty acids, and if there are associated conditions like vitamin deficiency, endocrine disturbances, high carbohydrate diet and high uric acid consumption along with impaired intestinal bacterial overgrowth, intestinal permeability, these patients can develop insulin resistance, dyslipidemia and fatty liver. So this is again a cartoon to show you the inflammatory cascade and the molecular level, how the fatty there is increased free fatty acids, mitochondrial dysfunction, eventually ending in the high lipids in the hepatocytes. What about the role of gut microbiota and NAFLD? A universal gut microbiome signature has been devised in NAFLD cirrhosis. The 8 species of gut microbiomes which are twice abundant in advanced fibrosis of NAFLD as compared to those without NAFLD have been found. 22 species are twice as abundant in mild to moderate fibrosis, particularly 2 types of bacteria, Prevotella and Bacteroid vulgaris. They have been found to be higher in these NAFLD patients. They produce excess of branched chain amino acids, and increased levels of BCAA have been identified in these patients with NAFLD as compared to those without NAFLD. So, the patient who has got a higher fat content either on imaging or non-invasive tests or on histology, if associated metabolic dysfunction is identified, then this patient is labeled as NAFLD. A patient who has cirrhosis with evidence of hepatic steatosis, where other causes have been ruled out, and again if metabolic syndrome
two things have been found, either hypertension, diabetes, pre-diabetes or high CRP, then he is said to be having an MFLD related cirrhosis. What are the non-invasive techniques to diagnose MAFLD or NAFLD? The simple two tests, all of you know, these are APRI test and FIB-4 score. Then one can do platelet count, AST-ALT ratio. And on imaging, there are commonly used tests are fibroscan, RFE, MRE elastography, and CT scan. And the invasive test is liver biopsy. Why non-invasive tests are to be preferred over invasive? Because they are reproducible, widely available, low cost, simple, safe, they are cost effective, and they can also assess the fibrosis. And one can perform it sequentially. The simple, as I told earlier, bedside tests are APRI score, NFS, that is non-alcoholic fatty liver disease, and FIB-4 score. Just 2-3 slides. So serum test are just 2 slides. Enhanced liver fibrosis score and imaging, as I told you, is a transient elastography and MRI and liver biopsy. So these are the two simple you can calculate on a bedside with a calculator, that is NFS score and FIB-4 score. And also on transient elastography, if the score is less than 6, there is no fibrosis. If the score is more than 13.6, there is an advanced fibrosis. So any patient who has no fibrosis or low risk fibrosis on either non-invasive test or fibroscan, then the repeat test is done at 2 to 3 years, whereas those who have high risk, he is to be referred to hepatologist and a liver biopsy is to be common. So these are the cutoffs for MRE elastography, APRI score and ELF score. There is a 20% rule for progression. So once the patient has developed F3, F4 fibrosis, 20% will go on to develop cirrhosis and 20% will decompensate. So these are again a battery of tests which can be done in patients who have got NAFLD. However, they have not been yet used in clinical practice. So again, a simple algorithm, diagnostic algorithm, any patient who has got a NAFLD, non-invasive test is to be done. If on FIB-4, APRI or NFS score, which is a low risk, the repeat test is to be done 2 years. If there is high risk, then he is to be stratified and then liver biopsy is to be performed and subsequent treatment is to be done. So what are the treatment modality? The basic treatment is again the reduction of the weight, 5 to 10% of weight loss, and in patients who have a lean NASH, 3 to 5% of weight loss is recommended. INSL recommends about 7 to 10% of baseline weight reduction either by diet or exercise. The diet which is advocated is the Mediterranean diet, which is high in unsaturated fats, less in saturated fats, and high in vegetables and fruits. The exercise which is recommended is about moderate intensity, aerobic or resistant exercise, about 30 to 45 minutes per day. That is about 200 minutes of exercise per week. The role of yoga is underexplored. Bariatric surgery is only indicated if there is not an advanced fibrosis or cirrhosis, and it should be done with caution in patients who have got a compensated cirrhosis and should be avoided in decompensated cirrhosis. The two types of bariatric surgeries which are recommended sleeve gastrectomy and Ruwa. It causes a marked weight loss and there is a profound effect on steatosis, but most of these patients they regain weight after 3 to 5 years. Duodenal mucosal C-surfacing is a new modality and there is a fibrosis score index course is improved in these patients. Intragastric balloon is another which has been found to be useful.
Sir, I'm extremely sorry to cut in between your story. At least cut it short.
There is a role of intragastric balloon in one study has been found to be useful and it improves a lot of variables. The treatment which has been tried is vitamin E, pioglitazone, and this vitamin E has been found to decrease the inflammation, decrease the steatosis. Pioglitazone has been found to be improve insulin resistance. However, there is a debatable effect on fibrosis. With pioglitazone, there is a weight gain, and with vitamin E, there is a risk of prostatic cancer. Saroglitazone, this is only approved in India, not in other countries, decreases ALT, and treatment duration with saroglitazone is only for 1 year. It's only phase 2 study available as a full paper. There is a debatable effect on fibrosis. The cost is high, available only in India. The semaglutide is a newer drug. There is one positive study, one newer study, still further studies are required. Another is a tirzepatide which has been used recently.
liver transplantation to be used for end-stage liver disease. So what is the general population varies from 9 to 53% with rural-urban differences. NAFLD accounts for about 63% of all cryptogenic cirrhotic cases. In the United States, it's the second leading cause of liver transplantation and third cause of HCC. Among patients with cirrhosis, progression to clinical decompensation ranges from 3 to 20%. The modification of terminology from NAFLD to MAFLD highlights the role of metabolic factors in better understanding of the disease, but it does not adequately account for genetic status. Screening should be done in all individuals older than 40 years with type 2 diabetes mellitus. Simple bedside scores like FIB4, APRI, NFS can help in stratification of patients. Lean hash has more lobular inflammation and they are at risk of serious related mortality. Primary prevention and early management of metabolic syndrome can have a huge impact on progression of NAFLD. A non-invasive test provides safer, cheaper and a reproducible way for assessment of liver fibrosis. A good dietary habit and exercise can make a huge difference. There is no definite medicine is recommended for NAFLD. However, vitamin E is used in non-diabetes, pioglitazone for diabetic as well as non-diabetes, and it is recommended for 2 years. Saroglitazone is a new drug on the block and it is to be used only for 1 year. Bariatric surgery is not recommended for advanced fibrosis cirrhosis. NAFLD is now becoming a leading cause of liver transplant, not only in West but also in Southeast and Western Asia. Thank you.
Thank you, sir, for an excellent summarization on NAFLD and MAFLD. I think the ideal take-home message in one sentence would be the realization of the importance of MAFLD, because we all take it in our stride in daily routine practice. So that was an excellent review of MAFLD, and I think due to shortage of time, we should be taking any questions on this.
Thank you, sir. Now we mark the end of submission of our fourth session of the day. We would like to request the chairperson sitting on the dais to please present a memento of appreciation to our speaker. May I have the honor to invite our chairpersons for the next session? Yes, sir. Dr. Ramesh Kumar, Head of Department of Gastroenterology at AIIMS Patna. Dr. Jyoti Prakash, Professor and Head of Department of Medicine at AIIMS Patna. Dr. Vaibhav Raj, Consultant Hepatologist at Ruben Hospital, Patna. Dr. Jayanta Kumar Ghosh, Consultant Gastroenterologist, Ranchi. Dr. Chandan Kumar Singh, Consultant Physician, Purnia.
May I request our speaker of the next session to come on the dais?
I am at the outset grateful to Dr. Dayal and Dr. Vijay for having given me this opportunity. The topic which has been allotted to me is incidentally detected hepatitis B virus infection. What next? How do we incidentally detect HBsAg? It may be detected during the time when the relatives of your patient go and donate the blood, or during a routine checkup as a part of executive health checkup, or when you are getting your child admitted to a medical college or a school as a part of the checkup, and more frequently when you are traveling abroad, especially if you are trying to be a migrant to another country. During travel, your visa application will require a complete checkup which includes hepatitis B testing, and incidentally also when you are applying for a job or else your family member is suffering from hepatitis B. These are the subgroup of the patient in which incidentally hepatitis B virus may be detected. So most of these patients will come to you in the practice of gastroenterology and hepatology, and they would like to know what is to be done. For us as a treating hepatologist, we have to sort out, is the disease acute or chronic? Does the patient have an active or inactive viral replication? Does the patient already have an advanced liver disease as a result of the underlying hepatitis B. Should we treat this patient or not? And once you start treating the patient, how do we monitor it? What is the outcome of the therapy? And then also, there may be subgroup of the patient who are incidentally picked up to be having hepatitis B, and this spatial population needs spatial answers. Whenever a patient comes to you with the incidentally detected HBV disease positive report, you have to have a area of investigation which includes routine biochemistry and assessment of the type and the degree of the viral application, in addition to presence of other viral infection like hepatitis C and hepatitis HIV infection. In addition, there may be some attempts at trying to know what is the structural damage to the liver, which can be easily assessed by a slew of investigation which are available to look at the morphology of the liver, like ultrasonography, fibroscan, etc. In fact, Dr. Parveen in his last talk has told us that if you want to assess the degree of damage to the liver by looking at the fibrotic component, there are various scores which are more intriguing and complex rather than easy to know whether the patient has an advanced liver disease or not. I think first and foremost important aspect of management of hepatitis B incidentally detected is we want to know, does the patient has a recently acquired HPV infection or patient has a long-standing infection. Any past history of blood transfusion, any past history of positivity of hepatitis B in the family, history of multiple sexual partner, or past history of liver disease are telltale evidences that this is possibly a chronic infection just getting onto the surface versus a recent checkup. Another important issue for us as treating hepatologists to decide, does the patient have an active disease? Our decision is based on three basic pillars of investigation. First and foremost is, does the patient have a replicative virus which can be documented by presentation of a raised DNA? Secondly, is this virus causing active inflammation which can be easily elucidated by looking at simple liver function test in the form of elevated AST/ALT? And finally, if there is a doubt, you can always go on to a liver biopsy to look at the evidence of chronic inflammation. As a group of gastroenterologists, I think it will be very naive for me to tell you that if you have telltale evidence of chronic liver disease, you don't have to bother about the indication and the intention of treatment. All patients with chronic hepatitis B and advanced liver disease do need treatment. But in the patient with other disease symptomatic does not have peripheral evidence of chronic liver disease, peripheral stigmata, you have to bank upon these fancy investigation like fibroscan, ultrasonography, etc. to know whether the patient has advanced liver disease or not. We did publish our guidelines on management of hepatitis B that also included management of incidentally detected hepatitis B. And if you look at the various guidelines, they do tell us that the key factors which decide in telling us which patient need treatment include a combination of the DNA, ALT, and the presence or absence of the E antigen and underlying cirrhosis. But if you look at the various factors which you have to consider when treating hepatitis B incidentally detected, you have this swathe and slew of investigations and the guidelines and the modalities and the DNA, ALT. And I'm sure sitting in a busy clinic with a huge OPD, I'm sure your head starts reeling as to what to do. How do we manage these patients? There are so many guidelines, there are so many indications for treatment, so many indications of not to treat. So what do we do? I think easiest is look at the way the evolution of hepatitis B treatment has been progressing from 2017 to 2023. I think even as much as we detest the intrusion of the China into our northeastern frontiers, but look at the guidelines. Irrespective of what is happening on the left side, whether you are having a cirrhotic liver, non-cirrhotic liver, E antigen positivity or not, the very fact that you have a DNA positivity, you have more and more indications of treating almost all hepatitis B and leaving very few subset of the patient who do not need treatment even in this subgroup of the patient. Once we have decided to treat a patient with incidentally detected to be HBsAg positive, we should know that in earlier era there used to be this number of drugs which will have a lot of resistance to treatment and lot of resistance will develop as you start treating them. But thanks to advent of these new drugs called anticavir and tenofovir TDF, and its newer modification, which is 1/12 the dose of the original molecule called TAP or tenofovir alafenamide, we hardly have any resistance. It has been shown up to a use of 10 years. There is no documented resistance either with entecavir or tenofovir. And hence for us as the presently treating hepatologist population or HPSAG, the choices are very limited. You have to choose either between entecavir and tenofovir. So let me start with this simple example of a young man incidentally detected to be having elevated ALT, DNA is high, there is no necroinflammation. What to do? I think if you see in the earlier guidelines in 2017 and even the ones which we published in 2018, any young man E antigen positive was so-called having to be a state of immunotolerance, it should not be treated. But the current recommendation clearly tell us there are a lot of caveats. Anybody who has a family history of hepatitis B, family history of HCC, has concomitant NAFLD or a fibroscan of more than 10, in addition to an age of 30 years as presented by EASL guidelines, is an indication for treatment. So there will be very few, even young people beyond the age of 30 years who are E antigen positive and have a replicative virus who will not require treatment. But if you look at this, another case of a middle-aged lady, elevated ALT, elevated DNA, and even if she has no evidence of necroinflammation or fibrosis, this is the patient who needs to be treated with long-term antivirals, which you have to choose between entecavir and TAF. And there are already established guidelines how to choose between the two. Given the choice, my preference is always for a drug called TAF, which is much cheaper in comparison to entecavir and has a wide range of indication. It is, in fact, is a drug which is a category B, can be safely used in pregnancy, and dose is almost 1/12 the dose of the conventional molecule called TDF. In fact, if you have to choose between the entecavir and TAF, the basic indications are whenever the patient is elderly and patient has a concomitant bone disease, entecavir should be preferred. Whenever the patient is younger, does not have a bone disease and renal disease, TAF should be preferred. In fact, that is how we choose between the two, and we should also remember that TAF is available almost at a cost of 1/3 the cost of entecavir. Another question which is important is once you have decided to treat, how long to treat. All patients with cirrhosis of the liver with incident-detected HbA positive should be treated lifelong. If it is E antigen positive non-cirrhotic, you may try to discontinue the therapy once you have achieved a stable DNA negative HbE antigen clearance after 1 year. There is a increasing data to show that even in E antigen negativity, you may end up stopping the treatment. But this recent data from Dr. Nora Tolat's group clearly showed that if you tend to stop antiviral therapies in E antigen negative disease, 1/3 of the patient may relapse, 1/3 of the patient will decompensate. So you have to be careful in stopping E antigen therapy. And in my practice, I think once you are HbE antigen positive patient, the chances of discontinuing the therapy are not there for the time being till we have new antivirals available for hepatitis B, like what we have seen DEAs in hepatitis C. Once the patient is on antiviral therapy, depending upon the type of disease process you have, whether you have a continuing inflammation or the patient has inactive disease or an active disease, you may have to vary the interval of your monitoring. Finally, coming on to the spatial situation, which will require spatial answers in hepatitis B. Pregnancy is one state in which if you incidentally detect a patient to be having HPSAG positivity, you may have to look at the concomitant parameters of the disease severity in terms of elevation in the ALT, the degree of rise in HPV DNA, as well as the presence of chronic and advanced liver disease on ultrasonography. What we need to address is, does this patient require treatment? What can be done to prevent the transmission of the baby, transmission of HPSAG to the innocent baby to be born still? What is the incidence of the transmission? Does every pregnant female require an LSCS? And what are the pros and cons of treatment in pregnancy for hepatitis B virus infection? And can these drugs be safely used in pregnancy? We again with INSL published these guidelines on management of hepatitis B and the various liver diseases in pregnancy. And these are the recommendations which are very clear that all women who are childbearing age should be screened for hepatitis B, and all those who are positive for hepatitis B, especially if the level is more than 4 log international units per ml, should be put on TDF or now even TAF at the 24 to 28 week of pregnancy, coupled with vaccination of the baby born at birth, both with the HPIC. So a combination of hepatitis B vaccine at birth, HPIC at birth and TAF in the third trimester of pregnancy decreases the viral transmission to the baby by about 95%. So if you are having a child who is incidentally detected to be HPSAG positive, this is the child which is typically supposed to be having an immunotolerant phase. That means that currently, not that it does not need treatment, but unfortunately the current antiviral therapies are not going to have any effect. So for the time being, we will have to wait and watch and just follow up these patients because the currently available antiviral therapy have no effect on the immunotolerant phase. Hepatitis B vaccination is something which should be routinely prescribed to almost all patients who are coming to you for any reason in your clinic. And even after the vaccination has been given, it is important to check their anti-hepatitis B antibody. You should be sure that the patient whom you have given the vaccine does develop an antibody. All members of the incidentally detected hepatitis B positivity should be screened for their presence of hepatitis B. If they have been exposed, they should be taken through the same drill of what we have done for the incidentally detected HPV positive state. If they have not been vaccinated, do vaccinate them because there is a known intrafamiliar transmission of hepatitis B. And those who have been given anti-HPV vaccination, they should be looked for their anti-HPV titer to be positive. Patients who are in the immunosuppressive phase, that means patients who are on transplant, patients who are having bronchial asthma or rheumatoid arthritis on steroids, should be taken care of because in this subgroup of the patient who are immunocompromised, there is a chance of reactivation of hepatitis B on immunosuppressive therapy. On this issue also we had publications of the guideline. There was a unique guideline in which we did publish that the patient who are having immunosuppressive therapies may be requiring special care if they are given immunotherapeutic drugs, especially drugs like rituximab, which have a higher incidence of the reactivation of hepatitis B. All patients who are incidentally detected to be HPV positive and have problems related to the disease processes outside of the liver do require antiviral therapy. These include vasculitis, purpura, PAN, or then the other glomerulonephritis. So some of ladies and gentlemen, all patients incidentally detected to be positive for hepatitis B should be screened for ALT and DNA. All those with elevated ALT and DNA should be treated with antiviral therapy. Now the choice is only between the two drugs, entecavir and TAF, and I have given reasons to you. Elderly patients, women and post-menopausal women and those with renal disease should be treated with entecavir. Rest all should be given the drug of TAF or TDF. In fact, these are the currently proposed guidelines by the US expert group, which is very easy and I think most of us should follow in our practice. If we test all adults with hepatitis B with triple panel, this is in addition to what has been detected. Let's look at this panel of HPSAG, anti-HPC total, anti-HPS antibody. Vaccinate all adults who are negative for all these markers. That means the patient has not been exposed. Please vaccinate all individuals. In fact, that is what I do in my practice for the last 30 years. This is the last slide. If HPSAG is positive, link simply to the HPV DNA. All with HPV DNA should be treated. Very simple. So look for these three markers. If all are negative, vaccinate all. If HPSAG is positive, do HPV DNA quantitative. If quantitative is positive, all should be treated. Treat all those who are HPV DNA positive because the currently available medication is only suppressing HPV replication. It is doing nothing to HPSAG positivity. And then after that, stage the liver disease and start surveillance for the liver cancer for patients with advanced liver disease because even if you have suppressed the virus, the patient will continue to have problems related to the liver disease. Thank you.
Thank you, sir, for your deep insights on the topic. If our delegates have any questions, we would like it to be kindly discussed at the lunch hour personally. We would like our speaker and chairpersons to please come forward and join you for a photography session and memento presentation.
First of all, one question. I think you should allow him to ask. You can ask.
Excellent talk as always. If patient with HPSAG is seroconversion and a non-serotic, what should be the strategy regarding antiviral? patient is non-cirrhotic, HbS/AG serial conversion has happened.
If HbS/AG has been
And
converted,
anti-HbS is more than 100, I mean more than 10, for example.
and then do an anti-HbS antibody. So there are two issues, you see. If HbS/AG has gone away from the blood, it would have occurred because of the two reasons. One is there may have been mutation in the virus and your HbS/AG surface mutant. In that situation, I'll do two things. I'll do HBV DNA and I'll do an anti-HbS antibody. If the HbS/AG has got cleared because of the immune activation, anti-HbS should be positive, then I'll not do anything. But if HBV DNA is suppressed in a patient who had HbS/AG, who had HBV DNA elevated earlier, I'll continue antiviral therapy till anti-HbS appears, because it may be mutated.
Second is what titer of anti-HbS you take as significant, number one,
Yes.
with HbS/AG negativity. Number two, whether one value is good enough, or you will take two values to make sure that HbS/AG zero conversion is happening.
Immunocompetent patient, any level of HbS antibody more than 10 is good enough. It is only immunocompromised patient that you have to jack up the liver to 100. That is because of the poor immune system you are likely to reactivate. Any single reading documented in an immunocompetent person any time in the life of more than 10 is enough. You don't keep chasing it later on.
That is to stopping therapy. That is the context of stopping antiviral therapy.
No, for antiviral therapy, I'll also go in for DNA. I said there are two things.
DNA is negative.
If DNA is negative, and anything more than 10 is good enough to stop the therapy, because what antivirals are doing is they're suppressing DNA, which is already suppressed. And if HbS/AG is lost, that means there is enough of viral replication which has got away with the HbS/AG positivity, but not enough to produce anti-HbS antibody. So I'll hold on.
Sir, one small question. Such type of patient, when you need a quantitative estimation of HbS/AG and when you need HBV DNA.
Yeah. See, in my practice, to start with, I'll always monitor both HbS/AG quantitative and DNA, because there is good data to show antiviral agents don't tend to decrease HbS/AG positivity. And if it keeps on coming, this is the patient which will encourage you to be consistently taking the therapy. Because as the HbS/AG is coming down, this is the patient who is likely to clear the virus. Because if you look at the natural history of the disease of HBV, natural history, the chance of losing HbS/AG is only 1% per year. But if you are having a substantial fall of HbS/AG, this percentage may be much higher than those who are not decreasing their HbS/AG.
Anil, is it data not only for interferon? This data of HbS is coming down.
Yeah.
Was used by Roche company for interferon continuation or stopping. Does it translate into oral drugs as well?
No, it is not. It does not translate, because the problem with advantage with interferon was it had a dual action. It had an antiviral infection and it was also immunomodulator. But I use it as a guide in the natural history with the disease also. If you see, after all, where does HbS/AG come from? It comes from two pools. It is one thing which is getting circulated in the blood, and second thing which is regenerating because of viral replication. If you are suppressing the viral replication, the incoming pool to the nucleus again decreases.
I think we need to wrap this session. We have already done
The end point is not the HbS/AG disappearance. This is the cccDNA which should go away, and which is very difficult. It is not a practical one. The HBV DNA, although it may not be raised, but there is a HBV DNA in the body. It has already integrated into the genome. So in that patient, are you justified in stopping the antiviral? Because you are not only preventing the development of cirrhosis, in many of the patients, there is a development of the HCC. So if you continue the drug, the antiviral drug, you are trying to prevent, one, the development of cirrhosis, second one, the development of HCC. So I don't think we should stop, although the INASAL or whatever, the guidelines may say that if HbS/AG disappears, we stop the treatment. But it is in the interest of the patient, so that they don't develop cirrhosis, they don't develop HCC, continue antivirals.
I'll give you an answer for that. If you look at the pathogenesis of HCC in hepatitis B, it is because of the integration of the virus into the genome, for which drugs like entecavir and TAF had nothing to do with it. So you have a cycle of viral replication, and at the fag end of the cycle you have an antiviral drug which is acting, which is futile. We are using it because we have nothing else to use. we are in a very primitive stage of use of HbSAg. There is no way antiviral drug trying to suppress the DNA translation of the enzyme will have any bearing on the DNA which has been integrated. So it will never happen. It is the replication which will prevent the further integration of the virus into the genome. But the HCC occurs because of the already integrated virus, for which you need to disrupt the DNA. The only technology is the trimming technique, which is still not available. Short of that, you cannot prevent by continuing. That is the reason you need to have surveillance. That is the reason you cannot leave them alone. That is the reason you need to have alpha-fetoprotein. 6 months.
Thank you, sir. I don't discontinue antivirals in such.
Yeah, that may be individual choice, but one should be clear. Even if you continue, you have to keep surveillance because.
Thank you, sir. Thank you, Bali.
Now I would like to request our chairpersons to kindly present the memento of appreciation to the speaker and join in for a photography session.
Chairperson for the next session on the choice, Dr. Anil Kumar Singh, Senior Consultant Gastroenterologist in Patna, Dr. Amit Kumar Banka, Senior Consultant Gastroenterologist, Dr. Asif Iqbal, Senior Consultant Gastroenterologist in Patna, Dr. Avinash Kumar, Consultant Gastroenterologist in Patna. Our next speaker for the session is Dr. Piyush Ranjan, who is a Senior Gastroenterologist in Sri Gangaram Hospital. Please continue with your speech.
Let the chairpersons be between 20 to 50%. Just to briefly remind you that the DSM-5 has changed the nomenclatures. The term alcohol abuse and dependence has been replaced by alcohol use disorder. So these alcoholic cirrhosis and alcoholic fatty liver disease, the nomenclature has changed. But given the evocative value of alcoholic hepatitis, this term has still remained unchanged. And also, if there are postgraduates here, to make them understand that that one standard drink is considered to be 14 grams of alcohol according to the American standards. The European standards has simplified 10 grams of alcohol, and significant alcohol intake is more than 3 drinks per day in males and more than 2 drinks per day for females. So what are the issues in alcoholic hepatitis? The diagnosis of alcoholic hepatitis, assessment of severity of alcoholic hepatitis, and then we come to the treatment of steroids, and what do we have beyond that. The clinical criteria for diagnosis of alcoholic hepatitis include significant alcohol intake for more than 6 months, and the period of abstinence should be less than 60 days. Significant alcohol intake is defined here as more than 3 drinks per day for women or 4 or 5 drinks per day for men. And the biochemical criteria is that bilirubin should be more than 3, AST should be more than 50 and less than 500, and ALT-AST ratio should be more than 1.5:1, and other causes of liver disease should be excluded. So, given these criteria, these patients fall into 3 categories, depending whether we do liver biopsy or not. If the clinical and biochemical criteria are met, these patients are labeled as probable alcoholic hepatitis. If you do liver biopsy, they become definite alcoholic hepatitis. If these criteria are not met and then you do a liver biopsy, this is then again definite. If the biopsy meets the criteria, this is definite. Otherwise, if the biochemical criteria and clinical criteria are not met and liver biopsy is negative, then this is possible alcoholic hepatitis. Up to 30% of patients with clinically suspected alcoholic hepatitis may have an alternate diagnosis on biopsy. That underlines the role of alcohol biopsy, doing biopsy in these patients. However, in day-to-day practice, it is seldom done and more important for the clinical trials. Now coming to the assessment of severity of alcoholic hepatitis, there is time-tested Madrid score, MELD score, Glasgow Alcoholic Hepatitis score, and the EBIC score, and Lille score, which is more a dynamic score to assess the steroid response. However, it has also been incorporated in the assessment of severity. MDF, long experience, however, there can still be few false positive. MELD, again, it is extensively a time-tested parameter in hepatology. However, the threshold for initiating steroids as per MELD is not very well established. ABIC and GHS have not been validated outside their centers from where they have originated, and LIS score is slowly finding its way. So the joint effect of MELD and LIS score is probably the best 60-day survival predictor. A patient who has a MELD score of 21 and a LIS score of 0.545 has a 1.94, nearly 2 times higher risk of death at 2 months as compared to a patient with the same MELD but a LIS score of 0.16. So the difference in mortality at 2 months here is significant. Now coming to the treatment of severe alcoholic hepatitis, once we establish the severity of alcoholic hepatitis, there are various aspects of treatment. The treatment starts from management of withdrawal, supportive therapy and nutrition, pharmacotherapy, predominantly steroids, liver transplant, and the newer treatment options. There are scores of them. However, we will specifically concentrate on the role of PLEX, FMT and GCSF in these patients who are either steroid ineligible or steroid non-responders. To underline the importance of alcohol abstinence is the most important factor in influencing the long-term prognosis after treating an episode of alcoholic hepatitis. Drugs which are can be used to control the craving, acamprosate and baclofen have been found to safe even in patients with significant liver disease. Now coming to nutrition, we have been seeing these slides in some form or another since morning. In 1 or 2 slides it has been shown. Dr. Sareen did show this similar slide. You have to ensure a good caloric intake, you have to ensure a good protein intake, and you have to give meals in divided pattern. So, however, if you look at the evidence of nutrition in alcoholic hepatitis, intensive nutrition in this study, in this prospective study, intensive nutrition was given 2 weeks of enteral feeding, tube feeding was done, and what was shown that in the intensively fed arm and the controls, the survival was not different. However, if we looked at total calorie intake in less than 21 calories and more than 21 calories, so this difference was significant. So the crux of the issue is that nutrition is important. However, in short term, when other things are very important, then the effect of nutrition might not show. In long term, definitely the nutrition is important, but in short term, at least ensure that the patient is receiving at least more than 21 calories per kilogram. So a similar result has been shown in review of randomized clinical trials that intensive nutrition in short term does not influence the mortality. Other antioxidants have not been shown to be beneficial. Zinc, which has a potential to modulate the gut permeability, may have some benefit. However, good studies have not documented this. Now coming to corticosteroids, these are the most extensively studied drugs in the treatment of alcoholic hepatitis. However, these trials have yielded inconsistent results. The issues with steroids are when to start, the contraindications, monitoring response, and what are the results of steroids. This EASL guideline clearly says that both EASL and ASLD guideline recommend the use of corticosteroids in patients who have severe alcoholic hepatitis when you have an MDF of more than 32. Contraindications are well known to most of us, so we'll skip this, and it is a well-known fact that only 25 to 45% of patients are eligible for corticosteroid therapy. However, infections, which are the most important contraindication, it has been shown that if these patients are treated, then these patients have a similar short-term outcome after being treated for infection as compared to patients who were not infected at the onset. The most common infections are SBP, UTI, respiratory infection, and fungal infections again are very common in nearly 15% of these patients, and the predictors of fungal infection can be younger age, high MELD, and prior glucocorticoid therapy. If you look at the results, this Madrid's trial came in 1978, and since there have been so many trials, but the most important trial which came for the support of steroids was this STOFA trial, where there were 4 arms in this trial, and if you look at the mortality, these bars show the mortality at 28 days. The mortality with steroid alone was nearly 14%. The mortality with placebo only was nearly 17%. The mortality with pentoxifylline only was higher, and the mortality with pentoxifylline and prednisolone combined was marginally less than prednisolone alone. So the conclusion here was that even though steroids decreased the mortality by nearly 35%, 39% at 28 days. This reduction did not reach the statistical significance, and there was higher infection in prednisolone treated group as compared to patients who are not prednisolone treated. Subsequently, by the same group, there has been a meta-analysis where they have looked at 4 different meta-analysis: corticosteroids versus controls, corticosteroids versus pentoxifylline, pentoxifylline versus corticosteroid, and pentoxifylline versus control. And again here the conclusion more or less is that corticosteroids improve the 30-day mortality without affecting 90-day mortality. And subsequently this article was again referred to by Dr. Sareen in his lecture, this real-world trial, retrospective trial by Arab et al. And again, the point which I want to mention here is that nearly 80% patients in this trial were cirrhotics, and again they showed that steroids just decrease the 30-day mortality and don't do anything to 90-day mortality or 180-day mortality. So, in addition, in this trial, they found that a MELD score of between 25 and 39 was the patient group in which the response would be best. So, having seen the response of steroid, which at best is dismal, but that is the best which we have at the moment. How do we monitor once we start steroid? LIL score, cutoff of less than 0.45 at day 7 has been included, and there has been some modification to it. Complete responder less than 0.16, non-responder more than 0.56, and the partial responder is 0.16 to 0.56. And subsequently, it has been shown that LIL score at day 4 is as good as LIL score at day 7. So we'll come to this algorithm later also, so I'll skip it here. So this was about the steroids. So what do we do in patients who are not responding to steroids or who have contraindications? The various pharmacotherapies which we have are in forms of various antioxidants, and there is an Indian study on bovine serum colostrum. So basically we are left with these 4 options: GCSF, FMT, plasma exchange, and liver transplant, about which we have emerging strategies. So in the interest of time, we'll skip these trials and come straight away to granulocyte colony stimulating factor. Here, what has been shown that GSF has a dual effect. It stimulates the liver regeneration and also helps in improving the WBC functions and improving the mortality in these patients. So these are the 7 trials. Dr. Virender Singh has authored 2 of these trials of GSF in severe alcoholic hepatitis, and this is the meta-analysis of these trials, and where it has been shown that GCSF reduces the mortality to the tune of 70% at 3 months in these group of patients. However, it is very important to mention that again, the Indian trials, the Asian trials have shown benefits, and the 2 Western trials which have been included in this meta-analysis do not show any improvement. Now coming to the role of fecal microbiota transplant, we all know that alcohol leads to dysbiosis, leaky gut and all that, and plays a role in propagation of alcoholic hepatitis. There have been very good studies regarding FMT in the severe alcoholic hepatitis. This was one of the earlier studies from ILBS, 8 steroid ineligible patients showing a good response at 3 months. Subsequently, the same group continued with nearly 51 patients given in FMT through nasoduodenal tube, and there was improvement in CTP score, MELD score at nearly 3. They followed these patients for nearly 1 month, and there was significant survival in these patients. And subsequently, the ILBS group has come with this randomized controlled trial of steroids and FMT, and what they have shown that there is a benefit of FMT over steroids. However, this study, there are a lot of issues with use of FMT. We do not know exactly the mechanism of action. We do not know what is the donor criteria should be, and there is a problem in obtaining the donor this thing. However, this study as of now published in 2023 shows that FMT might be at least as good as steroids in 3 months survival of these patients. Now coming to PLEX in ACLF, there is no separate study which looks at PLEX in severe alcoholic hepatitis. However, if we extrapolate these patients who have been treated with PLEX for ACLF, this is again the ARC data from the ILBS group. Here the predominant cause of ACLF, if you see here, is nearly 70% of ACLF in PLEX treated patients or standard medical therapy are alcoholic hepatitis induced, and plasma exchange has been shown to improve transplant-free survival in patients with ACLF as compared to SMT or the use of Prometheus. And the benefits of PLEX, as has been mentioned earlier also, is secondary to amelioration of SIRS in these patients. So now coming lastly to the role of early liver transplantation in severe alcoholic hepatitis. Most of these patients would be steroid non-responders or steroid ineligible. You have to use a very stringent inclusion criteria with three most important factors being that this should be the first liver decompensating events. If patients have had past episodes of severe alcoholic hepatitis, they should not be offered liver transplant. They should have a good psychosocial support and a good social support system, and they should be willing to adhere to abstinence. This was the first study published way back in 2011, 23 patients, steroid ineligible, and if you look at the 6-month survival, which was the primary endpoint, there was a significant difference. The upper red line shows 77% survival versus 23% survival at 6 months. And subsequently, there have been studies, and if you look at the studies lower down in this table, now they are looking at 1-year survival and 5-year survival in these patients, and this bar diagram will show you that patients with severe alcoholic hepatitis transplanted early have as good outcome, 5-year outcome, as in patients with ALD without cirrhosis and without severe alcoholic hepatitis. And obviously the middle panel of bars shows that patients with severe alcoholic hepatitis without early transplant, the survival bars do not progress beyond 2 years, so there is a very high mortality in these patients. And this similar results have been replicated by the Accelerate AH, which is an American multi-center consortium for liver transplant in severe alcoholic hepatitis, and 147 patients. 147 patients, the 1-year survival is 94%, and the 8-year and the 3-year survival is nearly 84%. So, in conclusion, to leave you with this algorithm, once the patient has got severe alcoholic hepatitis, you start with aggressive nutrition. If the patient is steroid eligible, go with steroids. Even if the response rates are dismal, this is the best which we have to offer. If the patient is steroid responder, continue with steroid. If the patient is a steroid non-responder, then we have a problem. If the patient is having an infection or an ACLF-like presentation, maybe use early GSF is maybe beneficial. If there are, then these patients should be, all these patients who are steroid ineligible or steroid non-responder should be assessed for liver transplantation. If there are no contraindications to liver transplantation, the patient goes ahead with liver transplantation. However, if there are contraindications to liver transplantations, then we have these difficult choices: FMT, PLEX, and GCSF. We have been at Gangaram using FMT. We have used FMT not in a systematic way, but with PLEX we have a systematic data, and we'll be publishing this data very soon. Thank you so much for your patient hearing.
For your extensive elaboration. Please come forward and join us for a moment of presentation. We have found a phone left on the podium. It must be of one of our speakers. Please collect it at the audio visual. May I invite on the podium our chairperson for the next session, Dr. Malay Sharma. Dr. Malay Sharma, sir, consultant gastroenterologist in Meerut. Dr. Deepak Kumar, consultant gastroenterologist in Patna. Dr. Karan Bhargav, consultant gastroenterologist in Patna. Dr. Arvind Kumar, consultant medicinal oncologist in Patna. Our speaker for the next session is Dr. Sameer Mohindra from SDPG IMS Lucknow. So please begin with us.
This academic meeting. I'll be speaking on endoscopic ultrasound, neurodiagnostic indications, both diagnostic as well as therapeutic. It's a big topic, but I'll try to finish in 15 minutes. The US has evolved from a pure diagnostic to a therapeutic tool, and there has been a paradigm shift in management with endoscopic method which we have, and it has a very good alternative to our interventional radiology and surgical management strategies. Initially, it started with fine needle aspiration because the needles which were available were fit only for fine needle aspiration. But now, in addition to fine needle aspiration, we can do a fine needle injection. And through injections, we have a lot of therapeutic potential. We can inject sclerosins, we can inject glue, we can inject hemostatic agents, we can do nerve blocks, neurolysis, we can ablate small tumors by instilling radiation seeds. We can put fiducials which can help our radiotherapy people in targeting the tumors better. And now a concept of installation of chemotherapeutic agent into tumors which are accessible by EUS is coming into vogue. What we do with transluminal UAS, we are kind of causing a iatrogenic perforation. And with advancement in available stents, especially lumen opposing metal stents, whether it's Spaxus, Axios, Hot Maggie, there are many in the market, we are able to do a single step transluminal stent delivery. What are the advantages of lumen opposing metal stents are? They are flanched, they are short in length, they prevent migration. They have a large internal diameter which helps us in better drainage as well as going through the stent and doing procedure like necrosectomy. Because of their structure, they have a very good opposing capability, and so they oppose the two adjoining structures. And because of the cautery at the tip of the stent, it helps us to make it a one-step procedure. There are various stents which are available in the LAMS category. It depends it depends upon the cost, it depends upon the availability, and depends upon the expertise which kind of stent you use. What lumen opposing metal stent does is it makes it a one-step procedure. You use one device, there is no need of exchange, there is no need of incision or dilatation, and when the steps are reduced, chances of complications are minimized. Now, primary areas of EUS which I will be discussing will be endohepatology, which basically means incorporation of endoscopic ultrasound in the field of hepatology. Number 2 promising field is endoscopic guided access and drainage, and number 3 is EUS guided tumor ablation. If you look at the spectrum of endohepatology, you start with diagnostic, elastography, contrast analysis, EUS. You come to liver biopsy, which is becoming a very good alternative to IR kind of radiology, biopsies. Then you do glue and coil, photosystemic shunt placement, portal pressure gradient measurement, and even paracentesis can be easily done with EUS. Now coming to EUS guided glue coil therapy, there are certain varices, gastric varices, like cardiofundal varices, that is basically IgV1 and GOB2, which are sometimes difficult to gain access with, and moreover they are large in size and the chances of rebleeding are much higher with conventional endoscopic glue therapy. So what are the advantages of EUS guided glue coil therapy are? Number 1, precision of the injection. Under real-time Doppler and even beam mode imaging, you can see where your needle is going and you can target the gastric varix properly. And it is especially relevant when there is an active bleed, because if the active bleed is there, recognition of the gastric varix which is bleeding sometimes becomes difficult, where EUS helps in picking up which varix is bleeding and targeting it. Number 2, in addition to sclerosins and glue, we can inject substance like hemostatic coils. An advantage of hemostatic coils is it reduces the flow in the varix when we inject first. And number 2, the amount of glue which we need to inject becomes much less as compared to endoscopic glue therapy. And number 3 advantage of EUS guided glue coil is you can see that your therapy is effective. There has to be a complete cessation of flow in that varix where you have injected. So these are certain advantages which we find. These are steps. We get a gastric varix, we see the color Doppler, we put in a needle, 19 gauge needle, and make sure that the signals go in. This is a short video, I can show if it works. Yeah. There are multiple columns. We have to identify the varix which is protruding into the gastric lumen, and generally we target the intramural varix or the feeder vessel. We target it and make sure that the signal goes. I'm sorry. Now, what are the comparison between the conventional endoscopic glue versus EUS guided glue coil? If you look at the hemostasis, initial hemostasis, it is comparable. I personally feel when you're doing the first injection for gastric varix, bleeding gastric varix, and if it is not actively bleeding, both are equal. But the difference lies in obliteration of gastric varices, recurrence of gastric varices, and rate bleeding. So definitely EOS glue and coil is a good replacement for endoscopic glue therapy as of now. EOS guided liver biopsy is another very common indication, and at our center more than 90% of liver biopsies are being done by EOS guidance, except patients where patient has got marked coagulopathy or severe thrombocytopenia or significant ascites, or patient is not fit for endoscopy. What is the advantage of EOS guided liver biopsy? It is a relatively short procedure. We give sedation which makes patient comfortable. You do it again under real-time Doppler guidance, and we can sample both the lobes. That's a big advantage, especially in conditions like NAFLD, and if there are multiple SOLs, both in the right lobe and left lobe, we can target both the sides of the lesion. Plus, it also helps when doing simultaneous procedure when you're doing a EOS guided liver biopsy. For example, in coming time, portal pressure gradient measurement will come into picture. We can do an elastography, especially if there are liver SOLs, along with the basic underlying liver disease. We look at any evidence of portal hypertension in the form of ascites. We can look at concurrent illnesses sometimes which we find, for example, gallstones, lymph nodes. We can target those lymph nodes if they are present so as to make a diagnosis. If we look at the results, diagnostic yield is more than 90% and complication rate is less than 2%. Majority of them are self-limiting, pain is the only thing, and patient can be discharged after 2 to 3 hours of observation. EOS guided portal pressure gradient is another promising technique which has come up. It basically means that you measure the portal venous pressure and you measure the mean hepatic venous pressure. And mean portal pressure is measured by putting a needle in the portal vein, and then we measure it, take 3 readings, and the average of 3 is taken as the mean pressure. And then we measure with the hepatic venous puncture and measure the hepatic venous pressure. Now, advantages are we can do simultaneously liver biopsy, we can look at endoscopic evidence of portal hypertension. Contraindications are similar to what are there for any interventional EOS procedure. EOS guided paracentesis we have started doing very frequently because we don't need to send the patient to radiology. Advantage is it can detect even small amount of ascites. Number 2, if it's a loculated ascites, it can be taken out. Sensitivity and specificity is quite high. The only problem is infection of the fluid which we take out. So we give prophylactic antibiotic very procedurally. EOS guided portal venous sampling is going to come up because what we know is, especially in pancreatic cancer, the malignant cells can get into the portal vein and we can pick blood from the portal vein and find out whether it is leading to metastatic disease or not. But certain things have to be kept in mind. A good cross-sectional imaging has to be done. Number 2, diagnostic EOS has to be done, and we have to make sure that we are dealing with a malignant lesion. But what we have to make sure that when we are doing this procedure, we should not have any metastatic lesion or lymph node in between because that can make it false positive. Another technique which may come up in future, though there are only studies in animals, is placement of intrahepatic portosystemic shunt where we puncture the hepatic vein. Mainly with EOS we puncture the left portal vein, get into the portal vein, and then place a stent. EOS guided tumor ablation, generally it is done by our IR people, but especially in difficult position like caudate lobe and left lobe, we can get into the tumor and we can ablate. Commonly used agents are alcohol and paclitaxel. EOS guided portal injection therapy, that is basically what you are trying to do is you are trying to minimize the systemic side effects of chemotherapeutic agents. If we have beads which are targeted with drugs, we can get into the portal vein directly and place it there. And animal studies have shown that the systemic levels are reduced by almost 50% while hepatic concentration is very high. So the chances of more efficacy and less toxicity is the logic. Coming to primary EOS BD versus ERCP, I will not discuss in detail. This is a debatable topic. It's a catch-22 situation. People who support ERCP is because less chances of complication with EOS guided drainage procedures. Proponents of EOS say that there are less chances of pancreatitis, but it's an equal situation. If you do a primary ERCP, chances of pancreatitis are 0 to 5%, but EOS guided biliary drainage is also not safe. There are significant complications associated with EOS guided biliary drainage, but it can be done as a substitute of ERCP where ERCP is not possible. Roundabout technique, what we try to do is we don't have access to the papilla through the ampulla, through the bile duct of PD through the ampulla. What we do is we get a guide wire and the EOS guidance and then convert it into a routine ERCP procedure. It can be antegrade from the stomach or it can be retrograde from duodenum. Primary endoscopic guided biliary drainage is generally done when there is a failed ERCP, when the papilla is seen but we are not able to cannulate because of either neoplastic infiltration or if there is a large periampere diverticulum, we are not able to see the papilla. Sometimes the papilla is inaccessible, we are not able to reach the papilla. There also it helps. These are two procedures which we commonly do. EOS guided cholecystectomy, which we do from D1. We identify the dilated bile duct, position it in a position where we can easily puncture it, make sure the color Doppler is applied because there are a lot of vessels in this part of the bowel, and then we place the stent. Another alternative is gastroscopy, which is done from stomach just beyond the G junction. We identify the segment 3 duct, puncture it, again under Doppler guidance, and then we inject contrast, delineate the biliary anatomy and place a stent. If you look at EOS guided biliary drainage and PTBD, why these procedures have come into vogue? It is basically because the complication rates of PTBD are slightly higher as compared to EOS guided biliary drainage. It's a prolonged hospital stay, higher cost, overall cost, plus chances of the tube coming out, blockage of the tubes, plus of course the cosmetic element. So EOS guided biliary drainage is a good alternative to percutaneous biliary drainage in a subset of patients where anatomy is conducive to EOS guidance. EOS guided gallbladder drainage, this is another promising technique which has come up. Indications are where patients are high risk for surgery. If percutaneous cholecystectomy tube has been placed and we want to replace it because patient doesn't want long-term tube, if drainage of bleed obstruction has not been possible either with ERCP or EOS guided bleed drainage, corticosteroidostomy, integrate stenting or corticosteroidostomy, and if there are contraindications for PDPD. But there are certain contraindications which we need to keep in mind when we are planning gallbladder drainage. There should not be a free gallbladder perforation, there should not be biliary peritonitis, there should not be a large volume paracentesis, large volume ascites. If it is there, we should drain it first. If patient is not fit for endoscopy and if there is no close apposition of gallbladder with the gut wall. This is a recent case which we did. This was a patient of malignant bleed obstruction. We had made 2 plastic stents, now presented with gallbladder obstruction. This we identify the gallbladder. There are 2 ways of doing it. Either we can do it from the antrum or we can do it from the duodenum. Duodenum is much better because less of peristalsis and it's a much better straighter position as compared to gastric antrum with a thinner wall. Results, anterior tube multicentric study which showed the technical success is very good. Complication rates around 10 to 15%. Now, if you compare transpapillary gallbladder drainage versus gallbladder drainage through EOS and percutaneous, the difference is of adverse events. If you look at the adverse event, PTBD has got significant adverse events. Most of them are not life-threatening, but they are considered as adverse events. Number 2, permanent drainage. We give a permanent drainage to EOS guided gallbladder drainage. So in malignant gallbladder obstruction, EOS is a very good modality for gallbladder drainage. EOS guided pancreatogastrostomy, this is a little complicated figure. We either go through the gastric antrum, puncture the PD and try to pass the guide wire through the papilla, the rendezvous technique, or we place the stent directly. We can go to the duodenal bulb and do the same. Important indications of EOS guided pancreaticoenterostomy is if there is chronic pancreatitis with obstruction of the main pancreatic duct. Disconnected pancreatic duct syndrome is a very promising thing because there is no other alternative, and for alleviation of pain and continuous leak, there is a very good modality if it is possible, and if there is post-vagal pancreaticodegenoscopy or pancreaticogastroscopy stricture. So it's a very good technique in a small subset of patients. The results are good, efficacy is around 70 to 80%, but it's a very technically demanding procedure and complication rates are quite high, 15 to 20%. So we need to be careful which patient we are doing it, and we should use it when either surgical or IR people are not able to drain the pancreatic duct. This is how we do it. We place our EOS scope, puncture the duct, dilate with either balloon or electrocautery, that is cystotome, and then place a stent. EOS guided gastroenterostomy is another very promising technique. Conventional indication has been where duodenal stenting is failed, but now it is emerging as a first-line therapy for gastric aortic obstruction. These are the steps. We place a guide wire, instill 100 to 200 ml of saline, mixed with methylene blue, dilate the vaginal bowel loop and try to find the bowel loop which is closest to the gut wall, puncture it with a 19-gauge needle and place a lumen opposing metal stent. Since it's a very useful technique, if you look at why it is important, if you look compare with dural stent, problem is number of interventions. If patient survival is more than 3 months, if the patient is very well preserved, EUS guided gastrovaginoscopy is a very good procedure. But if the survival is less than 3 months, then either of the two techniques can be used. If you look at the students, if you look at surgical techniques, if you look at surgical gastrovaginoscopy, it outscores the number of days, duration of the procedure, and how early the patient is able to take food. Contraindication, if there is a diffuse involvement of the gut wall, we can't do the procedure. Emerging US vascular interventions are, we can inject into rectal varices, ectopic varices, we can do splenic artery embolization. The kind of patient which we do is small aneurysms and when our IR people have failed. This is not the primary therapy for pseudoaneurysm. Interventional radiology still is the first modality to be done. If they fail or they are not available, then we do it. We see the aneurysm, see the Doppler pulse signal, we inject and see on the floor that we have done a complete job. Needle injection is done mainly for cystic lesions where we ablate either using alcohol or paclitaxel. Through the needle biopsy is a very good diagnostic modality where we are not sure about the type of pancreatic cystic neoplasm we are dealing with. Good diagnostic yield, complication rates are less than 10%, mainly pancreatitis and occasionally bleeding. Radio frequency ablation is coming up in cystic lesions which are not amenable to surgical technique or post-surgical risk patients. We can ablate these again by alcohol. Complication rates are less than 10%, mainly pancreatitis, peripancreatic collection, and occasionally bleed. Yeah, and this is my last slide. So, basically what I want to say is it's a one-stop shop. US can help in a number of procedures. But I want to say there are two statements on this slide. US everywhere, anywhere there is endoscopy. This is not the right statement. US can be done, US is possible, but any therapeutic procedure has to be done after a multidisciplinary discussion. Thank you.
Thank you, sir, for your insight on the topic. Now, I would like, I would request you to be seated on the dais, and I would like to invite the next speaker, Dr. Sundara from PMS Mumbai. So please continue with the topic.
So at the outset, I'd like to thank Ravi, Vijay and Dayal sir for this wonderful opportunity. So I'll be discussing approach to the management of colonic polyps today. These are the objectives of my talk. I'll try to cover epidemiology, how to assess polyps endoscopically, both morphologic assessment and image enhanced endoscopy. And lastly, of course, understanding the choice of endoscopic dissection techniques. So clearly, if you look at the history of colonic cancer, there have been a large number of celebrities who have been afflicted by colonic cancer in the West. Here you can see Neville Chamberlain, Ronald Reagan, Malcolm Marshall, and of course Chadwick Boseman, our very own king from Wakanda, who all had colon cancer at some point of time in their life. So clearly in the West there is a lot of knowledge and of course activism about colon cancer, and they treat it like a real pain in their ass. But it's not so much in India as yet, and I think India is still gaining. So if you look at epidemiology, it's been a disease that's largely been a disease of the West. It's possibly the third most common cause of cancer globally, second most common cause of cancer-related death. Around 2 million cases globally in 2020, and projected to increase to 3.2 million. But all of this largely again in the West. If you look at India, it ranks around 12th amongst all cancers, 5-year survival around 40%, around 7% in males, 3.5% in females. But why are we discussing this? We are clearly discussing because there's an increasing incidence rate. So clearly, in all the different registries between 2004 and 2014, there's been an increased incidence by 20 to 124%. And clearly, we need to look at targets to address for colon cancer, and the target to address are polyps. So polyps are, as we know, precursor lesions. There were two seminal papers, one by Morson's group in 1975, which described the phenotype of the adenoma carcinoma sequence. And of course, the genetic model was described by Vogelstein in 1990. And so we all understand that polyps technically lead to cancer, and addressing these polyps, of course, reduces colon cancer. So what about polyps in the Indian population? Are there any studies to understand what is the risk of polyps? So there are two studies that I could find. One was this large study from AIG, 34,000 almost copies. They found the overall polyp prevalence to be around 10.18%, and half of them were adenomas, so technically around 5% in the Indian population who undergoes colonoscopies. Again, they were more common in males, more common in the left colon, and a higher age was seen with adenoma and adenoma with advanced pathologies. Now again, if you look at the population with colorectal cancer, even they will have some synchronous lesions. This is our study, which showed a rate of around 2%, synchronous colorectal cancer, 7% rate of adenomas. So, but it's much lesser than what is seen in the Western data overall. So clearly, polyps can be divided into high risk and low risk polyps. There are non-neoplastic polyps which are hyperplastic, and neoplastics like the sessile serrated ones, hamartomatous and adenomatous. And in the adenomatous, there are something called adenoma with advanced pathology, the ones with size more than 10 millimeters, tubulovillous or villous pathology, and high-grade dysplasia. And why we say these are AAP are because there is an increased incidence of colorectal cancer over a period of time in these. So there are multiple predictors. One, of course, the size, the pathology, and the dysplasia, all of which show a higher risk in this group, in the seminal paper published in gastroenterology. But as gastroenterologists, whenever we see a polyp, all that we think of is, we need to cut it. We need to make sure. But clearly, like our cricketers, we need to know which balls to defend and which balls to play our shots to. So we need to understand how to assess polyps before we are able to cut them once and for all. So the endoscopic assessment, there are some essential considerations. One is, of course, the type of polyp, the morphology of the polyp, the risk of submucosal invasion, and the type of endoscopic resection that we plan based on all of these factors put together. Does size really matter? Of course it does matter. So the larger the polyp, the more the chance that there is cancer or high-grade dysplasia. This is a paper that was published in CGH in 2010, showed a 40% rate of cancer or high-grade dysplasia in polyps more than 30 mm in size. So clearly size does matter. The larger the polyp, the higher the risk, and it's more difficult often to resect these polyps. So Kudo gave his classification to understand the type of polyp apart from the size, based on the pit pattern. This was sometime in 1994. He used indigo-carmine at that time. But I think we moved from using indigo-carmine to the push of a button now. So we try to use narrowband imaging more and more now. And I think a large number of us, of course, have scopes which are enabled with this technology. And so nice classification was given in 2012. And it helped us to define which ones we can actually leave alone or resect and discard, the hyperplastic ones. Adenomas is often sent for examination. And of course, the cancers were ones that you did not resect. But then again, there was some ambiguity in type 2, and which is why the JNET classification was given in 2016. And it divided the type 2, the adenomas, into ones with low-grade dysplasia and the high-grade dysplasia or the intramucosal adenocarcinoma, 2A and 2B. And again, it made it a little difficult for us to understand. But then again, this is the standard classification that we go by now. And as endoscopists, we should be knowing these classifications if we are using them routinely in clinical practice. What are the issues with image-enhanced endoscopy in India? So we tried to survey with the help of the English Society. We tried to conduct a survey, and we found that a large number of centers are actually using scopes with image-enhanced technology. Only 10% did not use scopes without this technology. But then only 49% actually said that they were trained in some way or the other, and the training was largely at conferences, wherein it was a one-day training for, let's say, half an hour over a talk. So 80% respondents felt that they needed more experience in learning image-enhanced endoscopy, and clearly maybe this is an area that as Indians we can maybe address. Also the quality criteria for colonoscopy, if you see, the preferred bowel preparation, the use of antimotility agents, simethicone, and also the average withdrawal time was much lower in the survey. So clearly that is another area that as endoscopists we need to address to find polyps. Again, next comes the morphology classification. This is something that we use routinely in practice. This is the Paris classification given in 2003 for all superficial neoplasms of the GIT. And this is what we should be using anytime we see a polyp to diffract. So if you have a pedunculated polyp, it's 1P, a sessile polyp, it's 1S, that is more than 2.5 millimeters raised. And the others, the flat ones, will of course be 2A, 2B, 2C if they are elevated, flat or depressed. And lastly, of course, the excavated ones are 3. Usually these are the ones that you will not try and resect. Again, another term that is often used in colorectal cancers is LST. LST is laterally spreading tumor. This was given by Oka. Again, there are two types, LST granular and non-granular. So typically flat neoplasms can be classified this way, apart from the Paris classification, because there might not be uniform Paris classification in all lesions. You might find a combination, which is why this classification came forth. So an LST granular can be homogeneous, or it can be a nodular mixed type with different types like 1S plus 2A, and it can be non-granular, where it's again 2A or 2A plus 2C. So different types. And based on this, of course, the risk of submucosal invasion differs. So submucosal invasion in a laterally spreading tumor is much higher in the non-granular type than in the granular type. So the larger the lesion, the more the non-granular the lesion, the more the risk of submucosal invasion and the less likelihood for you to be able to resect it. So clearly this is the third factor that you will always consider, apart from the morphology, the submucosal invasion, and of course the size. Now of course we are spoiled for choice. There are multiple different resection techniques. Sometimes we use cold biopsy forceps, we can do polypectomy with EMR, ESG, and of course we can send for surgery. But there is always a need for en bloc resection. Whenever you see a polyp, you want to resect it en bloc. Piecemeal is a problem because of course recurrence is higher if you dissect piecemeal. So you want to try and avoid that. So what are the lesions that you want to ensure that you resect en bloc? Typically those with the LST-NG pattern, typically with the 5-1 PIT pattern. Again, large depressed types of tumors, mucosal tumors with submucosal fibrosis, especially in the background of ulcerative colitis, and of course the residual or recurrent lesions, you want to make sure that you resect en bloc. Now coming to different techniques, is cold biopsy sometimes is what is done for diminutive polyps. Is it really all that bad? If you actually, this is a recent systematic review published in GIE, and you will actually find that there was a higher complete resection rate with cold snare rather than biopsy. But then again, if you use the jumbo forceps in the subgroup analysis, they found that jumbo forceps are as good as a cold snare. For diminutive polyps, you can, the bottom line is cold biopsy with a jumbo forceps for a diminutive polyp is as good as a cold snare. So you can do whatever practice you're doing and use a jumbo forceps instead of a standard forceps. Coming to cold versus hot snare, this is again a debatable topic. So, but for small lesions, 6 to 9 millimeters in size, it's preferable to do a cold snare because post-procedure pain is lesser. For larger polyps, 10 to 19 millimeters in size, it's preferable to do a hot snare with a submucosal injection. You don't want an injury to the muscle, and you prefer using alunonate or other viscous solutions like gelofuscin instead of saline. And lastly, of course, if you have pedunculated polyps with a head that is more than 20 millimeters in size and a stalk that is more than 10 millimeters in size, you want to use some pre-therapy either with adrenaline injection or a clip or a loop at the base before you resect it. Coming to EMR, EMR is typically the standard technique for flat lesions. Now piecemeal can be done, but margin marking, it's preferable if you can do a margin marking, it might help you resect the lesion better. Submucosal injection again with a viscous solution like gelofuscin is better than saline. And the edges, if you're doing a piecemeal resection, make sure that you ablate the edges with the snare tip after the procedure is done, before you retrieve the specimen. So make sure that the edges are also ablated to reduce the risk of recurrence. Now what is underwater EMR? This has been quite in vogue. Now we have made this the standard technique, at least in our practice now, at least in our center. We routinely do underwater EMRs and do not prefer doing the inject and resect. This is a systematic review that we published again just last month. And clearly the en bloc resection rates for large lesions is much better with underwater EMR than with conventional EMR. So if you have the possibility of it doing an underwater EMR, it's always preferable. I mean, it's good to do an underwater EMR. It's actually as safe as a routine inject and resect EMR. Now coming to ESD, the issue is of course there's a high risk of complication. It's a long learning curve. Again, you require some complicated instruments for this. So, but the advantage, of course, is there's a high chance of en bloc resection and clearly long-term outcomes in terms of overall survival, disease-specific survival, and intestinal preservation rates are very, very good. But you would typically do this only for very, very large lesions. If you are in the rectum, typically for lesions more than 2 centimeters in size, always prefer doing an ESD over an EMR. Lastly, I'll just cover full thickness resection. This is again the new kid on the block. You have a large resection device, typically used for scar recurrences after an EMR or a polypectomy. Then again, there is not a lot of data on this front. So maybe over the next few years, there will be some data to come on this front. But typically in scar recurrences where lifting is quite an issue, you can use a full thickness resection device. It's an easy device. It's like a band. It's very easy to use, and you just pick up, apply the clip at the base and reset in the same device. Of course, you can send for surgery. Now, surgery, we've always been at loggerheads. I mean, we always tend to fight with our surgeons. Surgeons want to do cases. We want to do the same cases sometimes to try to do ESD. But clearly, I think we are all a team, and instead of the fighting, we should look at what best we can do for the patient. And like Atul Gawande has actually said, man is fallible, but maybe men are less so. So we are a team, and I think we should look at it as a team and do what is best for the patient. To summarize, this is how to approach. So if you have polypoidal lesions in the colon and rectum, you typically look at the image-enhanced endoscopy appearance. If it's a JNET 2A, it can undergo endoscopic resection. If it's a JNET 2B, again, you can do additional chroma endoscopy and they can undergo resection. With JNET 3, if there are obvious features of malignancy, best to send for surgery. Again, for endoscopic resection, if there are high risk features for submucosal invasive cancer, like a large size LST-NG or LST-G with a prominent nodule, if it's located in the rectum, then preferable that you send for an ESD. If these high risk features are not present, then you can do an EMR, you can do a piecemeal, you can do an underwater, whatever is best available at your center. For diminutive polyps, cold biopsy or cold snare either can be done. Cold snare, the retrieval rates are lower. If you have a 6 to 9 millimeter polyp, cold snare the polyp. If you have a 10 to 20 millimeter polyp, you preferable to use a hot snare. Lastly, last slide. For surveillance intervals, they are of course based on the type of polyp that you encounter. There are different surveillance intervals as defined by the AGA. I think it's a simple guideline, it's easy to follow in routine clinical practice. But I prefer in advanced pathology, especially lesions that a large lesion, more than 2 centimeters, if they're undergoing an EMR or ESD, it's best to surveil at the shortest interval possible, either at 6 months or at a year. Thank you so much.
Now I would like to request the chairpersons to present a memento of appreciation for our speakers.
Request our chairperson for the next session to please come up on the stage. Dr. Vijay Prakash,
Yes, sir.
Senior Consultant Gastroenterologist, Team Hospital, Patna. Dr. VM Dayal, sir, Head of Department at Gastroenterology in ISGCON Patna. Dr. S.K. Astrik, Senior Consultant Gastroenterologist at LMCH Patna. Dr. Rajiv Sinha, Senior Consultant Gastroenterologist at Curis Hospital, Patna. May I have the honor to request our speaker of this session, Dr. Govind K. Makharia, sir, from AIIMS, New Delhi, to come up on the dais. So, please begin with your topic.
Thank you so very much, Dr. Dayal and Dr. Vijay Center for kind light. And I see my teacher and chair, and it's a pleasure for me. So talking about IBS, I think all of us treat IBS. We say yes, IBS is a very common disease. So what's new in IBS and what's the change in practice we need to do in IBS patients? So let's take a case. This is a 46-year-old gentleman. He came to us with 5-year symptoms of chronic constipation, incomplete evacuation, had manual evacuation. He has to strain a lot and has to remove the stool by his fingers and has lower pain abdomen. He also had palpitation, chest pain, ghabраहट, tiredness, and also lack of sleep. So he went to multiple doctors. He was diagnosed to have a GID and IBS subtype, and he was treated with fibers, other laxatives, and other painkillers, but they were only mild response. So he went to many doctors, and multiple endoscopies, multiple colonoscopies was done. CT was also done. His clinical file became thicker and thicker day by day, but he only had partial response. Why it is so? Why patient IBS for this patient did not improve despite going to multiple doctors and getting all possible set of investigations? The reason being that if you look at IBS patients, if you use any drug, only 50% patient will improve, and others will not. The question is why? Why patient IBS won't improve? The first is that somebody sees this kind of file with a patient, you think this is IBS, you don't spend time. And you say, oh, IBS, no worry. So time is up, and we write prescription before patient speaks to us, or we spend time. And we think the IBS is a functional disease, therefore it's not important, it's not life-threatening, it's not cancer, it's not tuberculosis, therefore we don't care for it. And we ignore and stigmatize many times. This is the first thing we fail in IBS. The second, we don't try to understand why these patients' symptoms are not getting better despite using treatment. And the reason being, look at this patient that we discussed, that he had a 5-year constipation with pain abdomen, and he used to remove his stool by his fingers. He simply pointed towards that this patient has a pelvic floor dyssynergia. And if this patient I give fiber, the patient is going to worsen rather than getting better. And this whole, we don't analyze these symptoms, and therefore we prescribe without understanding. He also had anxiety disorder, which will not improve by painkillers or anti-constipating or antidiarrheal drugs. Therefore, it's very important that we understand the whole disease pathophysiology in a given patient. We all know that IBS is not caused by one factor. It's a multifactorial disease, and multiple causes are there, and all together lead to a symptom of GI dysfunction. That could be disorders of motility of GI tract, it could be bacterial infections, it could be microinflammation, a lot of data. So, and also visual hypersensitivity. They also have stress factors. Then diet is very important cause of IBS, and also genetic factors. So all these together are the extent of IBS. And no drug will address all of these issues. So you have to have a multi-form treatment, a multidisciplinary treatment. I'll come back to that why it's important. And the IBS symptoms are different in different patients. Somebody has mild IBS will respond very well with treatment. Somebody will have a severe IBS and they won't respond to what we prescribe. Therefore, overall, we need to think, we should change ourselves the way we think IBS. And IBS is an important disease and we must not try to ignore it. So what is the newer approach? First, that the name has been changed. People don't like to be called as a functional GI disease. I wouldn't like to, if I have IBS, somebody tells me it's a functional disease, Dr. Makharia. I won't like that. So the name is not changed to disorders of gut-brain interaction, right? And this is again combination of multiple factors. And this is an important, I would say this is an important step in advancement of understanding the IBS and also its treatment. So how do we optimize? If you get a patient with symptoms of constipation, diarrhea, or pain abdomen, how do I optimize care of this patient? The first, that to make a proper diagnosis, define subtype, define severity, what are the comorbid illness, and also try to define why these symptoms are there in a given patient. We all know we make a diagnosis of IBS by using Rome 3 or Rome 4 criteria, and I think all of us are aware. Two important things, pain abdomen or discomfort in abdomen, and also this gets better with passage of bowel movement. This is called IBS. And they are a chronic symptom. They are not acute, they are stays for weeks and months together. So once we say IBS, then subtype it. And this is extremely important, especially in our country. In our country, most people believe that they are constipated. And if you ask them, they pass 4 stools a day, but they still say, I'm constipated. And then we get confused. Since the word is used the term constipation, we take by verbatim that this is a constipation. It is not so. Always ask, and this is called a Bristol stool chart, and this can be downloaded on your phone or your clinic somewhere. You can put this poster there and ask which type of stool patient pass most of the time. Patient will say, I pass stool type 5 or 6, but still say constipated. This is not constipation. This chart is very important, and this tells us that type of stool will tell you, or will tell us, that how long the stool stayed in the colon. Longer it stays in the colon, it dries up and becomes type 1 and type 2. That is the dehydrated stool. But stays lesser in the colon, then becomes 5, 6, 7. This is diarrhea type. So showing this chart is extremely important. I think knowing this has changed my practice, and I understand these symptoms much better if I show this chart to my patients. Type 1, type 2 are constipated, type 3 is normal, type 3, 4 are normal, and 5, 6, 7 are diarrhea. This is the first thing. It also defines severity. All patients with IBS don't have a same kind of severity. Some patients have a severe disease, some have a mild form disease. And therefore, just 5 signs or symptoms are severe pain abdomen, the severity of distension, severity of or dissatisfaction in the bowel movement, and indifferent quality of life. And in scale of 100, ask how much symptom you have. And of total 500 numbers, if it is more than 300, it's called severe IBS. And this patient may require more intensive care compared to those for mild symptoms. Third, that most patients of IBS will have other symptoms like dyspepsia. Dyspepsia is not IBS. Right? Many patients will have psychiatric symptoms. Many patients will have migraine. Many patients will have a lower pain abdomen, especially women. Maybe not because of GI tract, maybe because of the other pelvic organs like uterus or ovaries. How they will present to us, like this one, endometriosis, become like IBS symptoms. And it is known that most IBS patients will have one or more other FGID, right? Also, they will have multiple somatic symptoms. They will say headache, they will say migraine. They will also have other psychiatric illness. And this is really important to understand, because unless you address these symptoms, the patients will not get better. So, making a diagnosis is easy, but how do I treat them? And therefore, putting everything together, somatic comorbidity, also psychiatric comorbidity, all together, there's a new term now used called multi-dimensional clinical profile. Right? And this is a combination of everything. We talk about the diagnosis, the subtype, if there is psychiatric comorbid illness, if there is a pelvic or dyssynergia. So all together, we make a diagnosis that's called MDCP. And then how do we treat? Today we treat by just giving them treatment of pain abdomen or constipation or diarrhea. For pain we give antispasmodics, for constipation anti-constipating treatment, and for diarrhea antidiarrheals. But despite using these class of drugs, only few get better. And one of the important things I want to emphasize here, that please listen to them. And listening to them, making a complete diagnosis will help them be better. So how do we improve our treatment algorithm, or how do we treat IBS much better. So the other treatment options we have is diet, modulating the microbiota of the GI tract, the peripheral and central neuromodulators, and other interventions. Coming first to diet, most patients with IBS, they will have a symptom worsening with diet. I think it's almost universal. They will know that a particular kind of diet worsens their symptoms. It's called trigger diet. So good to know what the trigger diet, and we can advise this patient to avoid these kinds of food. And the most important being the FODMAP food. Those food items which have a lot of undigestible carbohydrates, it's called FODMAP, and they will lead to symptoms, including if you have a taking apple. I know good size apple will have a 200 ml of gas, right? And those patients who are bloating, if they take apple, they may get worse. Lactose intolerance, or those who have a non-selective sensitivity like wheat. So these are the high FODMAP food. These may be replaced by a low FODMAP food. At the time, will not allow me to go into detail, but it's very important that the diet should look at. And there are data to show that if you give low FODMAP diet in those patients who didn't respond to primary therapy, this could be an option, and it does well. So coming to other, that is how do we change the gut microbiota? Because gut microbiota also is known to worsen symptoms of IBS. And there are a lot of data on probiotics, but till now, probiotics does not have a great role in patient IBS. So we might not like to use probiotic in patient IBS, and either single probiotic or combination probiotics. Most IBS patients will have a bacterial overgrowth, especially those who have a diarrhea type of IBS. And in those patients, if you use antibiotic, the rifaximin for 14 days, now there is data to show that at least 14% will get better. The third treatment is peripheral or central neuromodulator. Peripheral because you want to stop the signals which leads to GI motor dysfunction. And in that, one of the most important is serotonin. So one can use the drug which are serotonin agonists like prucalopride or even bisacodyl. Also, there are bile acid binders which can also lead to improvement in symptom of IBS. Now going down to those who have an IBS-C, one important thing we observe now that bile acid diarrhea, which is totally ignored globally, is also an important cause of IBS-D, and making very difficult to make a diagnosis. But in those patients who make a diagnosis, one can use cholesterol. Now coming to the fourth form of treatment, and I gave you an example, this patient who had come with peripheral dyssynergia. In this patient, the problem is that there is a lot of stool in the rectum, but he can't evacuate it because of dysfunction in the anorectal physiology. Therefore, if you give these patients fiber, the symptoms are going to worsen. You're going to understand that if they have peripheral dyssynergia, the only treatment is biofeedback. And this is a wonderful treatment. This can be taught, require an EMG or a manometry machine or with software, but a lot of physiotherapists also do biofeedback. If you have such facility, one can use. Those who have slow transit constipation, how do we know slow transit constipation? Those people who come that I pass stool once in 5 days or once in 4 days, this is not IBS. This is a slow transit constipation. In that patients, one would like to use chronic stimulants. If there is a small internal bacterial overgrowth, you give antibiotics, and many patients will do better with lactulose. And last treatment would be that a lot of patients who have a severe IBS will require, and if there is psychiatric illness, then they will require psychotherapy of various types. And the most important is cognitive behavioral therapy. So all of these are important, that, but can we do all alone? And are they useful? First, that to give all this therapy, you require dietitian, you require dietitian, you require a psychiatrist, you require a behavioral therapist, it also requires a hypnotherapist. So all of these are required. Now, if you have all of these, does it work? And look at this Mantra trial published about a couple of years back, was a wonderful study to show that one group of patients given normal therapy, which we gave, one group of patients were given all the combined agents that I just discussed. And treatment is better in those patients where we have a combined treatment. So now there is a movement that IBS patients we now understand a bit better, and this is truly a multidisciplinary disease and is to be used, and they are to be treated by a number of people. Just to recap, if you think of IBS, always subtype them, and for that, Bristol stool chart is the most important thing to do. Define comorbid illness, define any other subtypic illness in them, and you treat all of them together, and you will get a better outcome. With that, thank you very much for your kind patient, and I'm happy to take any question.
Thank you, sir, for your deep insight. Now, I would request the chairpersons to please present the memento of appreciation to our speaker and join in for a photography session. Now, I would like to invite next chairperson on the dais, Dr. Rajiv Kumar Singh, Senior Consultant Gastroenterology, Dr. Sanjeev Kumar Jha, from Department of Gastroenterology, Dr. Santosh Kumar from Department of Emergency Medicine, and Dr. Manoj Kumar, Senior Consultant, Dr. Manoj Kumar, Senior Consultant Gastroenterologist.
Thank you.